Good afternoon, everybody. I am Dr. Pranati Reddy. I am the Clinical Director of Maternal Fetal Medicine at BirthRight by Rainbow. On behalf of the management of BirthRight by Rainbow Hospitals, it gives me immense pleasure to welcome all delegates and faculty to the CME today on High Risk Obstetrics. This is an event which BirthRight has been conducting annually for many years now. However, in February 2020, a microscopic particle, can you hear and see me?
Yes, ma'am.
So the High Risk Obstetrics CME is something that we've been conducting annually for many years now. However, in February 2020, a microscopic particle brought the world and all our plans to a standstill. And amidst this time of lockdowns and waves, conferences have moved to a virtual platform. And this actually has brought and opened the windows of knowledge into our own homes, our offices, and our desks, which is actually a good thing. Today's scientific program, which is also on a virtual platform, has been put together with a lot of care in terms of content, ranging from the topical COVID pandemic to many areas of maternal health, in a quest to enable us to provide better care to pregnant women. And to deliver this well-designed content, we have invited excellent faculty, both international and national, who are stalwarts in their respective fields. And I would like to thank them for accepting to participate in this conference. I will now leave you all to the hands of Dr. Maitri, who will be the MC for this event. And I have absolutely no doubts that you will definitely enjoy and benefit from this academic feast.
Thank you, ma'am. Good afternoon. I welcome you all to today's CME on High Risk Obstetrics by BirthRight, Rainbow Children's Hospital. This is new and exciting as it's the first of its kind, a virtual CME involving national and international faculty. Before we start the session, I would like to inform you that all delegates will be on mute and do not have the facility of unmuting. Hence, kindly write down your queries and post them in our chat box. Dr. Shruti will address them and have the faculty answer them at the end of each session. Okay. Our first session of this year's High Risk Obstetrics CME is about a very relevant topic, hypertension in pregnancy. What's new? To educate us upon this, I welcome Dr. Vahida Suresh, Lead Consultant, Obstetrics and Gynecology at BirthRight, Chennai. Being a senior with over 25 years of experience, she's been trained in laparoscopy, ultrasound, fertility, and reproductive health, with her main focus at BirthRight being to build a holistic women's wellness practice. Over to you, madam. Vahida ma'am, can you share your screen?
Yeah, I'm just sharing the, can you see?
Yes, ma'am, yes.
Yeah. Good afternoon, everyone. It actually gives me immense pleasure to start this CME with my talk. And I think next 2 afternoons, we all as a group will be sharing our experiences and learning more about what are the complications which affects pregnancy. And as the CME rightly said, we have to save sick mothers, because as obstetricians and as medical practitioners, our aim is to save mothers whenever it's possible and to make maternal mortality to 0. So what hypertension, we all know, is one of the most commonly seen medical condition in pregnancy. And every day we have somewhere or the other facing women with pregnancy-induced hypertension, and our aim is always to save them. So before we run through what is new in pregnancy-induced hypertension, what is new, I thought we can just have a quick recap of what is hypertension and a little knowledge about what we know about hypertension before we go and see what is new in the management and prediction of hypertension. Preeclampsia is a multisystem disorder of pregnancy that forms an integral part of the spectrum known as hypertensive disease in pregnancy. Hypertensive disease in pregnancy is classified as 4 groups: gestational hypertension, where hypertension happens after the 20 weeks of pregnancy and usually disappears after 12 weeks postpartum. Chronic hypertension is a hypertension where the pregnant women present with hypertension, and usually this persists after the 12 weeks postpartum. And third is, we all know about preeclampsia and eclampsia, where preeclampsia is hypertension which presents after the 20 weeks with proteinuria, and eclampsia where there are convulsions. And new onset proteinuria, where a woman has hypertension, where there is new presentation of proteinuria after the 20 weeks of pregnancy. So chronic hypertension is when a woman already has hypertension and she is also diagnosed during pregnancy. So these are the things which has not changed from the time we have been medical students, and I think the future also, these are going to be the definitions which remains the same. So the major complications which affects 2/3 of women in this world, pregnant women, are severe bleeding, infections, preeclampsia and eclampsia. And in India, around 10 to 12% of pregnant women are affected by hypertension in pregnancy. To roughly say, every day there are at least 200 women in the world dying because of pregnancy-related complications. And it is very sad that in spite of so much of medical development, we are still not able to find out why this is happening and how we can prevent this. With the Millennium Goal, where the aim is to keep the right of women's health as a priority, like getting the world out of poverty, with preeclampsia playing such a big role, it is all the more a big responsibility on us to prevent this condition and bring down maternal mortality to 0. So what are the etiology and risk factors, what we know about hypertension? The risk factors are divided into maternal, in which it can be inherent or medical conditions. It could be pregnancy specific, or it could be paternal consideration. Under maternal inherent, it either affects women who are very young or women who are around higher age group. It is more common in nulliparous women in Afro-Caribbean origin, women with previous history of hypertension or cardiovascular disease. In medical condition, there is obesity, women who are obese with chronic hypertension, diabetic mellitus, and APLA and connective tissue disorders. When it comes to pregnancy specific, it is more commonly seen with women with multiple gestation, pregnant with oocyte donation, a new partner, women with urinary tract infections with hydradifam mole or hydrops fetalis. When considering the paternal consideration, it is more commonly seen with limited sperm exposure, barrier contraceptive, first-time fathers, and donor insemination. So what are the conditions which are in favor of all these risk factors? We all know that preeclampsia is autoimmune it looks like an autoimmune disorder. The reason being, many a times it shows an inflammatory reaction with type 2 immune response. It is also maybe due to placental hypoperfusion. Again, the reason why we see the preeclampsia in existing metabolic diseases like diabetes and connective tissue disorders. Also, one more important thing is there is a lack of placental cytotrophoblastic invasion of spiral arteries, which reflects the decreased production of placental growth factor, indirectly indicating the possibility of preeclampsia. New development. So what's new? This all of us knew about the risk factors, etiology. So what is new in pregnancy-induced hypertension? So there are new developments in predictive markers. One such, what we all use and regularly using and seem to have understood the importance, is giving women low-dose aspirin, especially in women who have possibility of developing hypertension, who have risk factors with connective tissue disorders or comorbidities, there is enough evidence to help suggest that giving aspirin from the 12 weeks does bring down preeclampsia by 17%. Also, there is 8% relative risk of reduction of preterm birth and 14% reduction in fetal and neonatal death. Yet another study is the SCOPE study, which tells us there is evidence that by giving vitamin D supplementation in women who had low vitamin D, there seemed to be a reduction in developing preeclampsia, though not studies have been conclusive. Another study which helps us where supplementation of calcium is another study which says in areas where there was low dietary calcium, those women seem to have developed hypertension in pregnancy, and the study shows replacing calcium supplementation in women with low calcium does bring down the reduction in preeclampsia. So the reason WHO has recommended that calcium supplementation be given to women in the second trimester of pregnancy with low dietary intake. Another study is measurement of glycosylated fibronectin serum levels in the first trimester. It's a longitudinal cohort study done showed levels to be significantly high in women with preeclampsia and remains highly throughout the pregnancy. Though look promising, it remains to be seen whether predictive ability will be useful to add it as a predictive value. Yet another study is the measurement of these factors PAP-A, PIGF, inhibin, activin, soluble FMS like tyrosine kinase and HCG. However, alone or in combination, there has not been enough evidence to tell that measurement of all these studies, all these measurements of all these factors will help us to predict the possibility of developing hypertension in pregnancy early. The other studies which are also seem interesting is the Optimum Study, which is optimizing titration and monitoring of maternal blood pressure. And other study is the BUM trial, which is blood pressure monitoring in high-risk pregnancy. In both these studies, they are longitudinal randomized controlled trials where women who have the risk of developing hypertension, and also in women who are in high risk in pregnancy. In both this group of women, they were advised to do home monitoring along with monitoring the blood pressure in antenatal clinics, just to understand whether by picking the high blood pressure early, can we bring down the incidence of hypertension in pregnancy, indirectly preventing the complications. The Darpa trial is yet another trial where the measurement of protein, we all know the gold standard is measuring 24 hours urinary protein, but this study aimed at understanding the different way of measuring urinary protein and to come to a conclusion what method is more conclusive. But all the trials, the more important or the more predictive value seems to be the angiogenic markers. The angiogenic markers in the diagnosis of preeclampsia is emerging. This seems more promising, which may have the potential of identifying women earlier in their disease course. Low maternal placental growth factor concentration, defined as below the 5th percentile for gestation or more than 100 picogram per ml, have demonstrated high sensibility and good negative predictive value for predicting the development of preeclampsia. Such two studies which are ongoing is one is known as the Prognosis Study, which is prediction of short-term outcome in pregnant women with suspected preeclampsia. And another study is the Parrot Study, where the placental growth factor to assess the diagnosis of hypertension pregnant women. These studies help us in measuring the placental growth factor and understanding whether by measuring we can predict, which seems promising. But as we saw, there are a lot of studies which is going on where we are supplementing with aspirin, calcium, and vitamin D. And equally, there are a lot of studies where measurement of the angiogenic markers or doing a Doppler studies will help us to predict. Unfortunately, hypertension continues to be one of the oldest diseases affecting women. It continues to be elusive to diagnose and treat, even with so many ongoing trials and studies, some of which were discussed in this presentation. To reduce maternal mortality, early diagnosis and management is key, and there is no fluke method of predicting hypertension in pregnancy, so there continues to be a scope for further research. However, as compared to the few decades ago, doctors are now more able to treat early and bring down the morbidity and mortality rate. This is due to the factors like advanced NICU care, and the government of India has made all pregnant women to be registered, and areas where we cannot, they are not available medical facilities, the village health nurses reach them so that they are all registered, and we are able to have a registry to pick up women early with hypertensive disorders. Yet another thing which is very common here is the mentorship, where all the peripheral hospitals have to send a list of the high-risk pregnant women who to the senior gynecologist. So in that way, we keep a watch on all the high-risk pregnant women, and we are able to pick up and treat them early. In spite of all these tests and all these trials, it continues to be elusive, and we are still waiting for that one magic predictor which will tell us that, yes, here is a predictor which will tell us this is going to be a pregnant woman who will develop hypertension and we can treat them. Till such time, the trials will go on, and as gynecologists and obstetricians, we have to be still on the lookout to pick up pregnancy-induced hypertension early and prevent the maternal mortality. Thank you.
Yeah, thank you, Dr. Wahida. I want you to unmute yourself so that you can answer the questions. There are two questions to you. One is, if in the first trimester scan, uterine artery PI is normal, but in the TIFA scan, if uterine artery PI is increased, is there any use of starting ecosprin 150 mg? Then, many reports like this we see in our clinical practice, and how to manage in these cases. This is what is the question asked by Dr. Uma.
Yeah, there is surely, see, because there is enough evidence to say that we can start, and with the facilities of fetal medicine, we are able to keep a close watch of the markers along with starting them on aspirin.
But yeah, Dr. Uma, the ideal time will be at 12 weeks, but at 20 weeks, yes. Evidence says that after 16 weeks, the benefit is not that great.
From 12 weeks is what it says that we have to start and then continue till term.
Yeah. And another question by Dr. Sudha is there any difference in the digital BP monitoring and the manual one which we do? So today, what is your opinion on that?
Yet today, many places, they do not have manual monitor. So what we do is, using the manual monitor and digital monitor, we titrate and use the, inform the patient what is the difference, and we can, because many of them are not able to have. So with the digital monitors now, what is available, I think the values are very good and we are able to use that effectively.
I think Dr. Maitri can take the
I once again urge all delegates to share their queries in the chat box. As they're all on unmute, Dr. Shruti will have the faculty answer them at the end of every session. Thank you.
Yeah, I think there's one more.
Wahida ma'am, can you stop sharing, ma'am? I need to. Our next session is a panel discussion on the age-old topic of Pprm. We today have an esteemed panel who will discuss the latest updates and various treatment modalities in the case of Pprm. Our moderator for this panel is Dr. Varalakshmi. She has been an integral part in developing protocols for evidence-based labor ward practices and currently heads our birthing facility in Kondapur. Our first panel member is Dr. Amrita. She is a lead consultant at BirthRight, LB Nagar. She is trained in minimal access surgery and has worked in UK for 7 years in a high-risk obstetric unit. She's also trained in advanced fetal monitoring. Welcome to the panel, ma'am. Next, we have Dr. Nalini Kant. He is known for his tireless efforts to give extreme premature babies their best chance of survival. He is a core member of our neonatal ICU team. He also takes great interest in heading the developmental clinic at Rainbow. He has multiple publications and research projects to his credit. Welcome, sir. Next, we have Dr. Meghna. She is a senior consultant in obstetrics and gynecology and a senior laparoscopic surgeon at BirthRight, Bangalore. Having many degrees to her credit, over the years, she has proven to be a great asset to our BirthRight team. Varalakshmi ma'am, I hand it over to you now.
Thank you, Maitri. Just give me 1 second. I'm trying to share my screen. Can you see the presentation?
Yes, ma'am.
Yeah. So a very good afternoon to all of you. Today, I'm going to do a panel with all the expert panelists with Dr. Amrita, Dr. Meghna, and our neonatologist, Dr. Nalini Kant, on preterm premature rupture of membranes. So we are going to mainly deal with how do we manage clinically when we come across a patient with PPROM. So we are going to mainly focus on the management. So when we see a patient with PPROM, our main challenges are whether you deliver immediately or proceed for expectant management. The problems with immediate delivery are problems of prematurity, secondary to prematurity in the fetus. And when we are considering expectant management, we have to be very watchful about the risk of maternal and fetal infection and sepsis. So the aim of this panel is how do we reduce the risk of premature problems in these women. At the same time, we should be very watchful about not increasing the risk of maternal and neonatal infections. So today I'm going to present a few cases where we routinely see in our daily practice. So the case one is, she's a 30-year-old primigravida. She has presented to us in our labor ward with complaints of leaking per vaginum. And her antenatal period was uneventful so far. So at 29 weeks, she just came with complaints of a sudden gush of watery leakage. So Dr. Amrita, would you like to take this question? So what would your first step be in managing this woman?
Sure, madam. Once this patient is coming into the labor ward, we need to ascertain what exact gestational age she is. And then we should do a thorough clinical examination and take a history and do a detailed examination to check particularly the temperature, pulse rate, and if she's having any contractions or not, and speculum examination to make sure whether it is a clear LICA draining or there is no LICA draining or not.
Yeah. So while you're doing the speculum and examination, I think it's be also very useful to do one vaginal swab. So which is very important. The first thing the neonatologist would ask for is, the swab report. So along with, confirming the gestational age, you should, and clinical symptoms, contractions, you need to check and do the speculum examination and take a swab. So, so she's confirmed that she's 29 weeks pregnancy. Her vitals and temperature are normal, and clinically on examination, she's not in active labor. And on speculum and examination, it was the leak is confirmed. So, what would you do now, Dr. Meghna? Would you do?
Once we establish the diagnosis of preterm pre-labor rupture of membranes, first we counsel the couple for admission. And the decision is made depending on risk versus benefit ratio. Here, I think the risk of the patient waiting is not very great. So I would go for expectant management, looking at her history, her gestational age, and I would like to investigate.
Yeah. So when you consider the expectant management, so would you like to do few other investigations before you decide on expectant management? So what would you do?
Yeah, usually after admission, we would already the vaginal swab has been taken. That would be sent for culture. Apart from that, I would also like to do her total counts, white blood cell counts, her CRP count, a complete urine examination and a culture. Also an ultrasound to see if the liquor has not drained out completely, that is not going towards anhydramnios.
Yes. So, and once you decide on expectant management, what are the interventions that you would like to do? So, Dr. Amrita, would you like to take this question?
Yeah, definitely we have to start her on antibiotics to prevent the risk of chorioamnionitis, and then steroid dosage, at least 2 doses of steroid, betamethasone 12 milligrams, 24 hours apart or 12 hours apart. And we have to coordinate with the neonatologist regarding so and so patient has come with PROM and if she has a risk of setting into labor. So these things we need to bear in mind.
Yes, well, the first thing we need to do in this is to involve our neonatologist when she has come with PPROM, and antibiotics definitely has a role in sorry, just a minute. Reducing the risk of the risk of infection. So according to the Cochrane database, it's proven that less than 32 weeks of gestation, when you start the antibiotics, it will prolong the pregnancy and decrease significantly the risk of maternal and neonatal morbidity. And it is gestational age dependent. Even at 32 weeks, there is an advantage in starting the antibiotics when we are deciding to prolong the pregnancy. And the second thing what Dr. Amrita mentioned is about steroids, which plays a very important role. So Dr. Nalini Kant, it has been proven that steroids are beneficial for lung maturity. Would you like to elaborate on this steroid coverage? And also about, what Dr. Amrita said about giving betamethasone 12 milligrams at 24 hours apart. So the dosage as well as the advantages.
Thank you for this question. So I will, in presence or in absence of PPRM, if the case is not frank chorioamnionitis, if we are dealing a premature delivery of 24 weeks to 34 weeks, there is no controversy in using antenatal betamethasone or dexamethasone. So antenatal steroid use and its efficacy well proven. Only the question comes here, what is the steroid? What is the choice of steroid? It is dexamethasone or betamethasone. If we have the molecule betamethasone, acetate and phosphate, then probably as per the international guideline, we can go for betamethasone. But unfortunately in India, the molecule is betamethasone phosphate only. Considering that WHO and Health and Family Welfare Department of India recommends 4 doses of dexamethasone 6 milligram IM rather than 12 milligram of betamethasone 24 hours apart. So if you're coming to choice of steroid, it is dexamethasone, WHO recommendation and Indian government recommendation. But if ideal molecule is available, probably that's different. But any confusion on PPRM, in presence of PPRM, should we use? It should be used. And as per the, if I will remember, the British Journal of Obstetrics 2017 publication says it acts in coherence. They are complementary to each other. In presence of inflammation, steroid acts better for the prematurity prevention. So we should go ahead with prevention of prematurity. That's the opinion I can say now.
Yeah. And Dr. Meghna, would you like to say what antibiotics would you prefer in women with PPRM while you're managing her as an inpatient?
Yes, according to guidelines, the antibiotics which we normally suggest are penicillin group, especially the ampicillin group. Ampicillin, usually we give 2 grams IV every 6 hours, along with erythromycin orally 250 mg or IV 250 mg every 48 hours, for every 6th hourly for 48 hours. Then followed by once 24 to 48 hours are over, we shift over to oral amoxicillin 250 mg orally and azithromycin or erythromycin. Now erythromycin 333 is not available, so we prefer giving 250 mg 6th hourly for until the leak stops or till 10 days. But usually it is 10 days after the documented Pprm. Here we should not give clavulanic acid based antibiotics because it is known to cause necrotizing enterocolitis in the neonates in Preprom with augmentin or ampicillin or amoxicillin clavulanic acid.
Yeah. I think Dr. Nalini Kant will agree with this, right? Dr. Nalini Kant, about avoiding giving, the common amoxicillin clavulanic acid combination. Right?
Just can I put little bit differently? Can I approach this problem
Yes.
little differently? Because erythromycin international recommendation, we know the organism Western country, and RCOG recommendation 10 days treatment. Coming to our own organism isolation in the 3 years follow-up, when we did 120 mothers high vaginal swab auditing out of 135 mothers, we got dominantly the most common organism is E. coli. Resistant to many of the normal conventional antibiotics. Though the same mother's urine isolated E. coli, which is sensitive, the high vaginal E. coli is resistant to multiple organisms. And then the next agent is Enterococcus faecalis. It is again sensitive to very, very different categories of antibiotic like linezolid and vancomycin. So how to go for? How to go? That's the dilemma. If we are talking about group B streptococcus, we are talking about positive gram-positive organism, Western country, talking about erythromycin 10 days, 250 milligram for 4 doses in a day. That's a different story. In India, if the E. coli next followed by Klebsiella, next followed by Enterococcus faecalis, and to our surprise, Candida is the second leading organism, Candida albicans. How to go ahead? What to choose? I don't know the answer. If you will come, come to the conclusion of consensus, I don't know the answer. Probably it's to be individualized depending on our experience.
I think the local, following the local antibiotic protocol is very important, Dr. Nalini Kant, because
individualized.
Yes, it is individualized. See, although we have a generalization of these, I think every unit should have their individualized protocol based upon their local antibiogram. And you have to have this discussion with the neonatologist and the microbiologist.
And then even if we are starting a broad spectrum antibiotic on the first basis, like in the first 24 hours, by 48 hours, we'll be getting the culture sensitivity results of whatever organism it is there, and then we can individualize the protocol accordingly.
Exactly. Yeah. So moving on, see, so in this case, we have done all the investigations, ruled out there is no chorioamnionitis, and we have started her on antibiotics, given steroids. So any other expectations from the neonatologist, from the obstetrician side, you would look for, Dr. Nalini Kant?
No, this indications probably delivery or other thing, the definitely obstetric decision. But as a preterm delivery PPRM, we are dealing, probably we will expect anti-steroid to be covered. And if indicated, magnesium sulfate, because in presence of sepsis, beyond the short-term outcome, the major long-term outcome I am worried is white matter damage or PVL injury in a newborn. And that can be little modified if the mother receives neuroprotective dose of magnesium past 4 to 6 hours. So if I will expect, if we are delivering a preterm delivery along with anti-steroid, whenever indicated, magnesium sulfate should be there.
Yeah, exactly, Dr. Nalini Kant. I think that we will deal with when we are going in for, when we are deciding that we are not continuing with expectant management, but we need to deliver in the next 24 hours, right?
Yeah.
Yeah. So expectant management, we have covered, investigations, we have covered what interventions we go for, neonatal counseling, and also consider in utero transfer where there are facilities, where there are no facilities where we can deal with preterm infants. That's also very important.
Yeah.
So investigations have come normal. She is stable and ruled out chorioamnionitis. We have completed the doses of steroids. She is on antibiotics now. So after 48 hours, what would you do, Dr. Amrita? Would you consider OP management or continue her to be as an inpatient?
Yeah, we can continue as an OP management provided the patient is aware when to come and she is good for follow-up, and she's staying nearby to the hospital and looking for the signs of the infection. If there is any abdominal pain or abnormal vaginal discharge, or if she's spiking temperature, she needs to report immediately. Otherwise, she will be coming for at least twice weekly monitoring to the hospital for both fetal heart rate monitoring as well as infection monitoring as well.
Yeah. So we need to counsel the patient properly, give them, in fact, we can give them a return sheet where, they have to know exactly what to look for and come to the hospital. So warning signs, like you said, abdominal pain with any abnormal vaginal foul smelling discharge or pain, or, also counsel them about the fetal movements and how frequently they have to visit the hospital. So generally, what is the frequency of visits you would suggest them, Dr. Amrita?
It has to be individualized, but at least twice weekly initially, and then you can change it as once weekly. And when they are coming, we have to do complete blood picture as well as CRP and fetal heart rate monitoring and ultrasound to check these are the important things which
And
you look
usually high vaginal swab also is very important.
for. There are mixed reviews regarding high vaginal swab, but on every occasion, if you are taking high vaginal swab, I think it will be a risk of reinfection. If they are having any symptoms, monitoring of the color of the liquor would be better. And if there is any false smelling discharge, examination accordingly. That's what I would suggest.
Yeah. Any cases where you are reluctant to do an outpatient management? Do you think any contraindications for outpatient management?
Obviously, if there is any episode of bleeding and it is liquor is very minimal, anhydramnios, and if this patient is spiking any temperature and showing the signs of infection, so that kind of cases, it is preferable to manage them as an inpatient.
Yeah, in some cases where they are very early onset PPRM less than 26 weeks, or if there's breech presentation where there's a high risk of abruption or cord prolapse, I think we would prolong the inpatient management. So now she has reached 34 weeks. Dr. Meghna, would you consider delivering this woman at 34 weeks?
I would prefer to continue because all the previous guidelines said we have to deliver at 34 weeks if previous history of PROM before 34 weeks. But now all the newer guidelines say continue at till 37 and after 37 also prolong if we can. If everything is perfect, if she has no signs of chorioamnionitis, the fetal heart monitoring is good, the liquor has not drained out completely, we can continue monitoring. Frequency of visits can come down to weekly once, and if the baby is fine, we can prolong till 37 weeks at least, and after that reassess.
Exactly. So the new guideline says that we can continue till full term, that is 37 weeks, provided all the parameters are within normal limits. Dr. Nalini Kant, do you think we should repeat the steroids at this stage? Because she has been given at 29 weeks, now she reached 34 weeks. We are still continuing the pregnancy.
34 weeks after the consensus, there is little not clear. And late preterm, I will say the disadvantage is more than the advantage in the late preterm. Okay. So I don't think anything needed if it crossed more than 34 weeks.
Okay. So the recommendation for repeat steroids at 34 weeks is not, because she's already reached 34 weeks and we are still planning to continue the pregnancy, we don't have to repeat the steroids at this stage. So that the first case which we discussed is a completely normal, uncomplicated PPROM where we haven't faced any problems. So coming to the next case, this is a precious pregnancy where she's a third gravida with 2 abortions in the past, and this is an IUI conception. She's booked with us at 13 weeks, and the NT scan showed that her NT is increased NT, and she's screened positive for trisomy 21. So after counseling the couple, they've decided for going in for amniocentesis. So she was scheduled for a planned amniocentesis at 16 weeks. She came with complaints of leaking per vagina. So we admitted her for observation, and we've sent all the investigations for the infection screen, which we discussed earlier, and also we started her on antibiotics and did an ultrasound to check for the amount of liquor. So the deepest pocket, because she was only 16 weeks, then we checked the deepest pocket, which was about 3 centimeters, which is not complete anhydramnios. So Dr. Amrita, what would you counsel at this point?
For the couple, we need to mention that the chances of miscarriage will be higher because there is a 1% chance of miscarriage for any amniocentesis, and PROM is one of the complications of the amniocentesis. And sometimes the leak may seal on its own and the pregnancy may continue. The need for admission and checking for the liquor and the presentation and all these are things are important, and the serial monitoring is also important, and looking for the warning signs. We have to warn the couple regarding the warning signs, and the coming for the follow-up. These are things we should be looking to. and we have to counsel thoroughly regarding the risk of miscarriage very much. And if there is when we are scanning and there is an anhydramnios and there is it is showing that this pregnancy is heading towards miscarriage or any other infection, the need for termination as well has to be explained to the patient in the partner.
Yes. So they have to be thoroughly counseled about not only risk of miscarriage, but also because this is a pre-viable premature rupture of membranes where she may, based on the scans, whether it's a complete anhydramnios, where there's a long-term risk of, lung development and limb contractures. See, all those things need to be taken into consideration, counsel them, and continue observation. So after 48 hours, she stopped leaking. Like you said, maybe it was a spontaneous sealing of the leakage. So she did not have any further leaking. Her infection screen was negative, and ultrasound showed a liquor, although it was a relatively less amount of liquor, where the deepest pocket was 2 centimeters. The cervical length was normal with no funneling. So at this point, we've decided to discharge the patient with thorough counseling, and we have not opted for termination of pregnancy, which the couple has agreed upon. So again, the same lady, she has come to us at 24 weeks with, again, complaints of leaking PV. Again, we repeated her the infection screen, which was negative. And the growth scan we did was showing that the fetal growth was 600 grams with oligohydramnios of 8 centimeters, and Dopplers were normal. So would you consider giving steroids at this point?
Yes, definitely the steroids should be given. And at least that will help. The rest of the things which are looking fine, and we can continue the pregnancy on OP basis and give the steroids.
Yeah, as Dr. Nalini Kant was saying that, after 24 weeks, and also we need to involve the neonatologist at this point. So we would definitely give the steroids at 24 weeks and continue the pregnancy at this point. So she reached, we started monitoring her after 24 weeks with weekly infection screen and fetal heart rate monitoring, and we actually do high vaginal swab weekly. So at 25 weeks, when she came, her high vaginal swab was showing Enterococcus fecalis, and it is sensitive to piperacillin and tazobactam. So at this point, based upon the HVS report, would you consider delivery, Dr. Meghna?
If the high vaginal swab shows infection, it might not have ascended to the uterus and caused an infection. So still, if the mother is comfortable, not spiking fever, her temperature is okay, her pulse is okay, and the uterus is not tender, then I would like to treat the infection and wait and watch, and repeat the high vaginal swab a week later, so that we document that it is treated. Because there is no documented evidence of chorioamnionitis.
Exactly. So we have to take the overall picture into consideration. So because her other parameters, CBP, CRP was normal, her clinical condition was stable. So we continued with conservative management. So, and then on further follow-up, her repeat HVS shows that there was no growth, and scan showed that there was severe oligohydramnios at 28 weeks. The interval growth was normal, but the LICA was very less, only 4 centimeters of AFI, and her Dopplers were normal. So would you consider delivery at this point?
At 4 centimeters, still there is enough LICA for the lungs to expand. I don't expect bronchopulmonary dysplasia or limb contractions for 4 centimeters. So I would still like to wait until if the AFI drops further, or she might set into labor on her own if the AFI is dropping.
So we continued the pregnancy in spite of severe oligohydramnios because other parameters were normal. And at 29 weeks, she presented with pain abdomen, and on examination, she was in active labor with breech presentation. So Dr. Amrita, what about the role of tocolysis in PPRM?
Tocolysis causes more harm than good, whatever the evidence is saying till now. because this patient has already completed the course of steroids and she's 29 weeks pregnant and she's already in labor. That itself means that there is an infection which has taken over and she has set into preterm labor. So I would not give any tocolysis for this patient. But at the same time, we will not even augment the pregnancy or augment the labor. And
because she's in active labor and in breech presentation, we have, we went ahead and did an emergency C-section for this woman, and it was a 1.2 kg male baby born. Dr. Nalini Kant, how would you manage this apart from the problems with prematurity? Because she has had a HVS report which showed prior to delivery, we did a HVS and it showed Enterococcus faecalis. So would you manage this baby any different?
This baby, any baby, Pprm, when we are speaking Pprm, onset less than 32 weeks before, if a pregnancy less than 32 weeks pregnancy gestation before, then the chances of infection to the baby 10 times higher. Chances of morbidity to the preterm is 4 times higher. Chances of mortality is 3 times higher. That's the statistics as per the international database. So I know the baby is born now with prematurity, but this Prprm history is increasing the morbidity and mortality a little higher. So I should be more careful and monitor. And to 2.5 times higher antibiotic use happens if you evaluate the baby with the septic marker and the culture, and we follow the babies. In those group of babies, they are 2.5 times likely they receive more antibiotics if the Pprm is, with the mother had Pprm history less than 32 weeks. So I will be more careful to monitor the RDS, which sometimes related to Pprm, or later I should be worried in late case, 28 days or further, I will screen the brain, because any infection antenatally can affect the white matter of the brain. Preterm baby's brain white matter damage is a possibility. That way I will be careful. Otherwise, I will treat as per the prematurity and its complication. But we should be more careful, more monitoring, more vigilant when we know the history.
So the choice of antibiotic would be based upon the high vaginal swab report, or do you start a broad spectrum antibiotic for this?
High vaginal swab, if specific sensitivity pattern is available to us, it will guide us. But high vaginal swab, if the Pprm history wise, Pprm also can be of more than 14 days. Pprm can be onset more than before 28 weeks before. It can be prolonged Pprm. It may be 1 week before the HBS or 6 weeks before the HBS. A lot of factors we have to take into consideration. So we will took the culture. We will take the sepsis markers of the baby, standard whatever regimen which covers usual organisms like Vipersil and Tazobactam or anything we can start. But if I know Enterococcus faecalis like organism and HBS which is within 2 weeks of deliveries, then I will respect the sensitivity pattern and treat the baby with broad spectrum antibiotic till the culture is available for the baby. Otherwise, a standard regimen, I have to follow the baby's culture. It is not the mother's only information, but baby's own blood culture is going to come in 24 to 48 hours. We can plan accordingly. It all depends on previous report and the baby's overall clinical status and the reports.
Thank you. Let's move on to the next case, which is, she's a primary at 31 weeks. She presented to us with painful uterine contractions, and it was a confirmed PPROM. She is pyrexial with a temperature of 100 degrees and a pulse rate, she's tachycardic. Even the CTG was showing that there's fetal tachycardia, and she's having regular contractions. So on examination, the cervix is 2 centimeters dilated. So 2 weeks prior to this, the woman has presented with, threatened preterm labor, and she already received 2 doses of betamethasone. So Dr. Amrita, would you go for expectant management or immediate delivery in this case?
I will admit this patient and do a detailed history as well as examination, and take sepsis profile, actually complete bed picture, CRP, complete urine examination, vaginal swab, and start her on broad spectrum antibiotics. And she already had a steroid cover, so we can wait for if the temperature is settling or not. There is no role to immediately deliver this patient immediately. If we know the source of the infection, we can treat it accordingly.
Yes. So whenever we see a woman with fever and PPROM, I think first thing we need to do is we need to do a thorough evaluation to look for any other sources of infection. So because, when we put this question, many a times the answer I get is that we immediately deliver. So my point here is that first we need to evaluate the cause of fever and then treat. So this patient, we have admitted her, given her IV fluids, started her on paracetamol, and her CUE has showed that there are plenty of pus cells. So we have started her on cefixime and oral erythromycin, and the fever has settled down, and she has proceeded to 34 weeks. So the message here is that you should screen for urinary tract infections and vaginal infections if the woman has presence, with fever, and start her on appropriate antibiotics. So on the learning points in the cases 2 and 3, what I would reiterate to everyone is that do not deliver based upon a single parameter. As you have seen that, when there is a HVS positive report, or if there is severe oligohydramnios, or when you see fever, you have to take the overall picture into consideration and then only act upon, because delivering without a proper indication means we are giving a lot of morbidity in terms of complications with prematurity. So this is a very, the learning message that I would like to give to everyone here. So moving on to the next case is the case study 4, where a 31-year-old with a third gravida, 2 previous preterm birth she had, and neonatal deaths. So at 29 weeks gestation, she came with complaints of leaking per vagina. So on examination, her vitals were stable, her uterus is relaxed, she's not in labor, her fetal heart is good, and scan 1 week prior to this was normal. So on speculum examination, the os was closed and there is no leakage of fluid seen. So how would you proceed in this case? So she came with a history, but on examination, you did not find any leakage. So how would you proceed? Dr. Meghna, would you like to take this?
In this case, if patient gives a strong history about history of leak, then we should strongly recommend to follow that. Plus a high index of clinical suspicion is needed. Here, I would like to admit the patient or observe her with a sterile pad. If the speculum once might not show leak, it might show up later. Or I would wait for the leak to show up on the pad, or treat her like Pprm if she strongly gives history of leak, gush of fluid or something. Otherwise, I will also get an ultrasound to see if the fluid has come down from last ultrasound to now. There are multiple tests available, but at the end of the day, it's only the patient history and the clinical suspicion which act as strong markers. There is nitrazine test and there are biochemical markers.
What is your opinion on the biochemical test? What is the current evidence on? See, although practically we are not doing it, we should know about what are the tests that are available. So could you just elaborate on the biochemical testing?
The first problem with biochemical markers is it's not available easily. In India, I think the availability is almost very limited. In US, they're doing it. Second thing is the cost of the test. It is expensive, but in a low-cost setup, it might be problematic. Third thing is, if the test turns out to be positive, yes, it is diagnostic. But if it is negative, we cannot rule out Pprm. So we should not base upon only biochemical markers for diagnosis of PPROM.
Yes. So according to the NICE guidelines, so they say that in although it is not available, and as you rightly said that the clinical suspicion and admission and observation is more important things. If the results, if you have the available tests that are, the placental alpha microglobulin, which is, famously called as Amnisure, or, insulin-like growth factor, can be done in women where there is suspicion of PPROM. But they also said that you cannot just act upon based upon these tests. You should take her clinical condition, her medical and pregnancy history into consideration before we act upon these tests. And the recent guidance also says that do not use the nitrazine test to diagnose PPROM, because the false positive rates is very high with in these cases. So in this, as Dr. Nalini Kant has explained us how they would manage in an ICU, is there anything that you differently do in these babies in the first year of their life, Dr. Nalini Kant, for when they come for follow-up?
No, if the neonatal stay time, no added morbidity, probably our follow-up is not going to different. It is depending on the risk factor of the baby and the morbidity of the baby will decide the follow-up. Depending on the Pprm, the previous antenatal factors, not. But if there is a diagnosis and antenatally specific diagnosis antenatally, or later during the morbidity, added morbidity, we will do differently the follow-up little more frequently. Otherwise, standard is 4, 8, and 12 months we do the follow-up. And vaccination schedule is not going to different with the baby. It is absolutely, it will be norm as per the chronological age of the baby. The vaccination not going to be different.
So coming to the last case, where this is a 35-year-old primate gravida who attends the delivery suite with the discharge per vaginum at 30 weeks, and she's also DCDA twins. She has diabetes, which is poorly controlled on insulin. So on examination, there's the leakage is confirmed on per speculum examination. So Dr. Amrita, would you give steroids?
Yeah, definitely I'll admit this patient and consider course of steroids. Keeping in mind her sugars will shoot up, she may be considered for a sliding scale if need be.
Yes, so definitely steroids are indicated in this case because one is because her sugars are poorly controlled. We need to admit her, give her insulin, and then the insulin dosage might be need to be adjusted. And also the reason I put this question is that some people are worried about chances of infection with Pprm and high sugars. So, but definitely the advantage is based on the risk-benefit ratio. The benefit is more than the risk in this case. So, would you manage any differently from singletons in DCDA twins with Pprm, Dr. Meghna?
It would not be greatly different. The monitoring has to be a little closer because as such twins, the chances of Pprm is higher and preterm delivery chances are higher, but rest of the treatment in the form of steroids, antibiotics, and the magnesium sulfate will remain according to singleton protocols only.
So they may need more frequent monitoring of the second twin as well. So when she starts contracting and the delivery is inevitable at 29 weeks, so she's steroid covered, what additional intervention would you expect from the obstetrician, Dr. Nalini Kant?
If the growth and the Doppler along with the normal premature baby when we are going to deliver, the growth pattern and the infection like Pprm, is it there or not? If Doppler abnormality is there or not, on the growth pattern, growth interval, how it happens. These are the few additional things I would like to know, along with the antibiotic use in the mother, which already we discussed. We highlighted same practices, antenatal steroid, antibiotics, but along with that growth and Doppler, I will ask the specific questions to prognostify the baby when it is going to deliver, how to monitor.
Yeah, at 29 weeks, would you consider giving magnesium sulfate? Would you elaborate on magnesium sulfate?
Yeah, any baby who is going to born shortly, if less than 30 weeks, or some guideline talks about less than 32 weeks, probably we are getting an opportunity, at least we should expose a loading dose of magnesium sulfate with few hours of maintenance magnesium sulfate. So the doses are 4 gram or 6 gram, that is probably obstetric protocols are very clear, but there is these two regimens, 4 or 6. But I will like to see that the mother receives magnesium for the baby's neuroprotection if they're going to born before 30 weeks and some cases before 32 weeks. So it's definitely going to help us.
Yeah, so it's proven that magnesium sulfate is, according to RCOG guideline, they say it's less than 30 weeks, you need to give magnesium sulfate, and that is helpful for neuroprotection in these babies. And see, this is the key recommendations, like a summary. I'm going to tell you that it is, history is very important, and clinical examination on sterile speculum examination, you need to confirm, and in places where it is available, if the clear leak is not seen, you can use the test. But in our setup, we still follow, admit and follow whether they to see for any signs of leakage, further signs of leakage. And we have clearly discussed on antibiotics and steroid coverage, which is of advantage to any women with preterm. And once again, I would like to reiterate here that we should not take a decision based upon a single parameter. And according to the recent guideline, till recently, I think in 2019, they have changed the guideline saying that you can continue the pregnancy till 37 weeks when all the parameters are within normal limits. And magnesium sulfate is useful for neuroprotection. So these are the summary points I would like to say, and everyone should have this, PPRM registry to make a note of all the cases in the unit. Thank you.
Ma'am, we have one question for you in the chat box, which says, what is the role of probiotic use in women with recurrent history of preterm labor or preterm rupture of membranes?
Probiotics.
Yes, ma'am.
There's no role of probiotics for recurrent history of premature rupture of membranes, but you need to see if there is any cause for, recurrent PPRM. When there's a woman who presents in this pregnancy with a previous history of PPRM, because one of the commonest reasons, if it is not an iatrogenic PPROM, we need to look for sources of infection like UTI, and in some places they also do vaginal swabs, and prophylactic antibiotics, there's no role. It's only if you see any source of infection, we can treat them with antibiotics.
We've also discussed this, ma'am, but we have a couple of doctors asking us, till what gestations should magnesium sulfate be given?
Recent guideline RCOG says 30 weeks, but there are guidelines where, in ACOG, they say that up to 32 weeks we can give. The advantage is up to 32 weeks, right, Dr. Nalini Kant?
Sir, we can't hear you, sir.
Mute you, sir.
Audible now? Is it audible?
Yes, sir.
Many of the consensus statements are 30 weeks. But a few of the guidelines, two international guidelines, picks up to 32 weeks. So we can extend the benefit up to 32 weeks when the neurological injury we are expecting more. That's the rationale behind that. Dose, the latest trial, the dose again. So dose, I don't want to go detail because it's a different area. But still, the latest guideline, the largest guideline, talks about 6 grams instead of 4 grams.
Yes.
Sir, we have a question for you. What is the prognosis of babies born to mothers with chorioamnionitis?
This question, repeatedly we speak that question, the morbidity, mortality is going to be higher, antibiotic need is going to be higher. But if pathologically we will see two morbidities we are interested, chorioamnitis babies, if long term, if less than 28 weeks onset, prolonged onset of chorioamnitis can cause pulmonary hyperplasia and very difficult to handle, later can result into chronic lung disease. Otherwise, the baby can have short term like RDS and requiring more antibiotic and late onset of sepsis. And the third important thing, any infection or inflammation, not only infection, chorioamnitis, any region, inflammatory mediators release, hit hard to the brain of the baby can result into periventricular leukomalacia later. So I'm worried about these terms, so I will monitor. It's not that every baby develops those things, but I should monitor and support the baby if the baby is born less than 32 weeks from a mother with PPRM history.
Okay, ma'am, we're running a little ahead of schedule. So if anyone would like to discuss anything in PPRM, we're more than happy.
With recent COVID and PPRM, I think in women with COVID positive, we had, in the experience, whatever we had, we have delivered most of the women with PPRM. So because the fact that it has led to PPRM itself is that the maternal infection, which has led to the severity of the infection, where in, the interest of the mother, we had to deliver these women immediately in COVID positive women. Any comments, others?
Preprom and preterm birth go hand in hand. So always we need to remember that preterm birth, it is happening in first pregnancy. The chance of it recurrence in the next pregnancy is quite high. And we also always need to look, because these patients are always anxious when they come across a preterm baby, the kind of situation they face, running around the hospitals, and then if they conceive again, the risk of having one more preterm baby. So these things we need to do an early counseling, and we need to rule out any other risk factors which are causing the preterm birth and preprom, like obesity, smoking, and improving the general health. All these things have to be reiterated to the patient so that they can, at least we can avoid, and to report to the hospital immediately if they are noticing any early signs of labor or prom, so that we can extend the duration of the gestation and reduce the risk of prematurity and associated complications.
Nalini Kant sir, we have one question for you. What antibiotics do you use in babies born to mothers affected with chorioamnionitis?
This discussion we have done, the protocol may say different, but the approach is individualized medicine now. So individuals, unless I know the high vaginal swab sensitivity and the organism, how to decide. If I don't know the pattern, only there is a risk factor of Pprm, I will stick to my neonatal protocol, which talks about cefotaxime, ampicillin, gentamicin, or in some cases of extreme premature, less than 1200 gram piperacillin tazobactam to start with, after evaluating my baby. But if I know the pattern, a hospital or a facilities pattern of organism, the way we spoke, our patterns are E. coli, Enterococcus faecalis, next to that is Candida. So I will evaluate accordingly. But if I don't know, I will stick to the neonatal protocol, which talks about one or two combination antibiotic like cefotaxime, aminoglycosides, or ampicillin for the newborn baby.
Thank you, sir. Varalakshmi ma'am, we have a couple of doctors asking the same question. Can we conclude that anhydramnios is not an indication for delivery in a case of PPROM?
Yeah, it's again individualized. So as I told, it depends upon the gestational age, the growth of the baby. Based upon, anhydramnios is different from oligohydramnios. So if it is anhydramnios completely at very early on gestation, pre-viable gestation, then probably after counseling, you can consider termination of pregnancy, because these women are at risk of, lung hypoplasia, pulmonary risk of pulmonary hypoplasia and long-term complications. But when it comes to, viable period where there is Pprom, we can still consider continuing the pregnancy with anhydramnios, but then again, we need to keep a very close monitoring of the fetal well-being. So it has to be individualized. We cannot generalize saying that you can continue the pregnancy with anhydramnios.
Can anyone elaborate on the magnesium sulfate protocol, dose for preterm for neuroprotection?
Usually we give 4 to 6 grams loading dose, followed by 1 to 2 grams, but 2 grams continuation is known to cause more neonatal death. So I think 1 gram is what is usual consensus. 1 gram from, depending on whatever the local protocol is, 1 to 2 grams, but 1 gram from anywhere between 6 to 24 hours, just before delivery.
At the same time, we have to keep a close eye on monitoring of further magnesium sulfate toxicity, as well as maintaining the respiratory rate and urine output and reflexes. This is very important. Anhydramnios, as Madam has mentioned, most of the times once they are going into anhydramnios, they usually set into labor even before we start. If it is a very early anhydramnios, they end up in miscarriage. The main thing is we have to counsel the patient, as Madam has mentioned, the risk of anomalies and bands, amniotic bands, and all these things have to be elaborated in detail. But if it is in the later pregnancy, anhydramnios, or 34 weeks and it is coming to anhydramnios, and that is the time we can deliver, because the benefit of delivering the baby is high when compared to continuing the pregnancy. So it is purely dependent upon the gestational age when you are looking for this anhydramnios.
And one thing here, ma'am, we have seen a lot of postnatal depression in PPROMs. This is, I think, we have to address mental health issues once after the delivery. This is also very under-assessed thing in India, probably. Postpartum depression because of taboos and all. Postpartum depression is very common in people with preterm labor or PPROMs. That is something which we have to address also. Postpartum depression questionnaires are there, which we can hand it over to them, family support.
There's also a question on steroid dose, whether it is same for twins as singleton. It is the same dosage for twins and singletons.
No, ma'am, please go ahead, ma'am.
No, there's no difference in the dosage of steroid for singleton and twins.
Sir, this is for you. By continuing the pregnancy till 37 weeks, did we see a significant better outcome in those babies, sir, rather than delivery at 34 weeks?
Absolutely. Absolutely. The day it goes in natural environment in the uterus, I will be the happiest person to see later than the earlier. The day, not weeks. There's a 3 weeks difference. It's a huge difference for the baby. If somebody will ask me, are you happy at 37 weeks, 2 days, or happy at 37 weeks, 6 days? I will be happiest to see at 37 weeks, 6 days. 4 days counts. 1 week increases the survivability. Each week adds to the survivability of the baby and to the brain of the baby. So absolutely, each day we can prolong as a team. It is better for the baby.
Thank you, Varalakshmi ma'am and the panel. I think that was an extremely informative session. Thank you once again.
Thank you.
Thank you. Thank you all.
Thank you. Our next session is a keynote address by Dr. Alison Langford on peripartum cardiomyopathy. Due to time constraints, we will now play a recorded video by Dr. Alison. However, I'm extremely pleased to let you know that she will be joining us as a panel member in the next session. Questions regarding this presentation will be answered by Dr. Alison at the end of the next session. Dr. Alison S. Langford is an assistant professor at Department of Obstetrics, Gynecology and Reproductive Sciences, Division of Maternal Fetal Medicine, Critical Care Medicine at R. Adam Cowley Shock Trauma Program at University of Maryland, USA. I now request you to start sharing the video.
Good afternoon. I would like to thank Dr. Shruti and colleagues for inviting me to speak about peripartum cardiomyopathy during this high-risk obstetric conference. I work as a maternal fetal medicine specialist at the University of Maryland in Baltimore, Maryland, and as an intensivist in the cardiac surgery ICU. I appreciate your attention today to this very timely and important topic in obstetrics. While obstetric hemorrhage is the leading cause of maternal mortality in India, cardiovascular disease and hypertensive disorders of pregnancy make up approximately 6.7% of the maternal deaths in India between 2007 and 2014. One can also see the regional variation in the contribution of hypertensive disorders on maternal mortality in India, such as more affluent states, hypertensive disorders make up a greater proportion of maternal deaths. This is in contrast to the leading cause of maternal mortality in the United States, which is now cardiovascular disease. Cardiomyopathy, which will be the focus of our discussion, made up 11.5% of maternal deaths in the United States between 2014 and 2017. The estimated global prevalence of peripartum cardiomyopathy is about 1 in 1,000 pregnancies. The cardiomyopathies are a diverse group of disorders characterized by structural abnormalities of the heart muscle, and they are associated with substantial morbidity and mortality in pregnancy. Abnormalities can be characterized as anatomic, histologic, or functional. The etiologies of dilated cardiomyopathy are diverse and range from familial to toxin exposure, infectious, inflammatory, and stress-induced. When the etiology is unknown, dilated cardiomyopathy is considered idiopathic. This is where peripartum cardiomyopathy fits in. There are many other forms of cardiomyopathy that we will not discuss in detail today. These include hypertrophic cardiomyopathy, rare cardiomyopathies such as restrictive cardiomyopathies, and left ventricular non-compaction. The underlying etiology of cardiomyopathy can be assessed by looking at regional wall motion abnormalities, wall thickness, trabeculations, aneurysms, presence or absence of valvular heart disease, measurement of pulmonary artery pressure, and the presence of diastolic dysfunction. The diagnosis of cardiomyopathy, of dilated cardiomyopathy, is made in the setting of ventricular enlargement accompanied by reduced systolic function in one or both ventricles. As the ventricles become remodeled, they start to take on a spherical appearance. This video takes you through several characteristic echocardiographic views and shows the dilation of both ventricles and overall reduced systolic function. The video starts in the parasternal long axis view, which highlights the impaired left ventricular dilation. This is the parasternal short axis view, which also highlights left ventricular dysfunction. And the apical four-chamber view is an excellent view to assess regurgitation in both the mitral and tricuspid valves. And the last view, as you see in this clip, is highlighted with contrast and really defines the borders of the left ventricle and shows the spherical appearance. Peripartum cardiomyopathy is a form of dilated cardiomyopathy in association with pregnancy and in the absence of structural heart disease or other known explanations for left ventricular dysfunction or heart failure. The diagnosis of peripartum cardiomyopathy is one of exclusion. The timing is often loosely defined as heart failure presenting towards the end of pregnancy or in the months following delivery. A more precise definition outlined by the National Institute of Health workshop in 1997 for the timing of peripartum cardiomyopathy include the final 4 weeks preceding delivery and up to 5 months postpartum. The degree of left ventricular impairment is defined as a left ventricular ejection fraction less than 45%, or fractional shortening less than 30%, with or without ventricular dilation. Heart failure is a clinical syndrome, and left ventricular ejection fraction is the primary metric for differentiating heart failure syndromes. It is important to distinguish between the terms heart failure with preserved ejection fraction, or HFpEF, and heart failure with reduced ejection fraction, or HFrEF, because these are terms that cardiologists will often use and influence treatment with goal-directed medical therapy. The American Heart Association defines heart failure with reduced ejection fraction based on a left ventricular ejection fraction less than 40%. Risk factors that are well established for peripartum cardiomyopathy include African American race, chronic hypertension, and hypertensive disorders of pregnancy, maternal age greater than 30, multifetal gestation, and higher gravidity and parity. In addition, there are trends towards an increased incidence of peripartum cardiomyopathy in some areas worldwide, including 1 in 100 live births in Nigeria, 1 in 299 live births in Haiti, 1 in 1,000 pregnancies in South Africa, and 1 in 1,100 to 1 in 31,000 pregnancies in the United States. There are also significant variations in mortality, ranging from 1% to 30%, depending on the study population, clinical definition of peripartum cardiomyopathy, and access to quality healthcare services. Although the etiology of peripartum cardiomyopathy is unknown, it has been postulated that there is a two-hit mechanism involving host susceptibility and a systemic angiogenic imbalance that is critical in the pathogenesis of this disease. Factors contributing to peripartum cardiomyopathy including genetic mutations, decreased serum selenium, viral disorders, immune-mediated cytokines, autoimmunity, increased oxidative stress, and an inappropriate response to the hemodynamic changes of pregnancy. On the other side, leading to imbalances in systemic angiogenic factors, including the upregulation of angiogenesis inhibitors, increased levels of byproducts of prolactin, known as vasoinhibin, which we'll talk about more later, and increased levels of soluble FMS-like tyrosine kinase, or SFLT1, a protein that is derived from the placenta. SFLT inhibits vascular endothelial growth factor and plays an equally important role in promoting preeclampsia, suggesting a potential interaction between these two disorders. Women with peripartum cardiomyopathy generally present with symptoms of congestive heart failure, such as shortness of breath, dyspnea on exertion, orthopnea, cough, fatigue, and peripheral edema. The most frequent clinical findings are attributed to congestive heart failure and its severity. These clinical findings include tachypnea, tachycardia, crackles, increased JVD, and pitting edema in the lower extremities. Many affected women are overtly hypertensive at the time of presentation, an overlapping sign of preeclampsia. Red flags that should trigger emergent evaluation include shortness of breath at rest, severe orthopnea, a resting heart rate greater than 120 beats per minute, a systolic blood pressure greater than 160 millimeters of mercury, an elevated respiratory rate greater than 30 breaths per minute, and an oxygen saturation less than 94%. While chest X-ray, EKG, and lung ultrasound are useful in the workup of such patients, transthoracic echocardiogram is the standard of care for diagnosis. The role of cardiac MRI in the investigation of peripartum cardiomyopathy is unclear at this time. The echocardiogram generally shows left ventricular dilation and systolic dysfunction, right ventricular and biatrial enlargement, mitral and tricuspid regurgitation. One can also see in the echo findings on the left a pleural effusion. So as discussed before, this is the peristernal long axis view. This is the left ventricle, the left atrium, the left ventricular outflow tract and the aortic valve, and the right ventricular outflow tract. You can see impaired left ventricular function. You can also see a small pericardial effusion. Here's the aorta, and here you can see a pleural effusion. In this view, this is the peristernal short axis view, where again you can see impairment of left ventricular function. You can also see right ventricular enlargement, and you can also see flattening of the interventricular septum, suggestive of RV strain or volume overload. In the European Worldwide Registry of 411 patients, right ventricular function was normal in half, mildly abnormal in approximately 35%, and severely abnormal in 10%. One of the best views to image right ventricular function is the apical four-chamber view, which is shown here. This is the right ventricle, and this is the right atrium. You can measure something called the TAPSE, or the tricuspid annular plane excursion, which is an indicator of right ventricular function. This image shows right ventricular dilation and again impaired right ventricular function. The differential diagnosis for peripartum cardiomyopathy includes common causes of pulmonary edema from both increased vascular permeability and cardiac failure. These include hypertensive cardiomyopathy, superimposed preeclampsia, valvular heart disease, and sepsis. Less common causes include prolonged use of tocolytic agents such as terbutaline, pulmonary embolism, thyrotoxicosis, lupus, and ischemic cardiomyopathy from myocardial infarction or spontaneous coronary artery disease. Once the diagnosis of peripartum cardiomyopathy is established, one can initiate goal-directed medical therapy. The management guidelines for heart failure applied to treat heart failure in the general population can be implemented to treat women presenting with peripartum cardiomyopathy after delivery. These guidelines are published by the American Heart Association and provide a nice algorithm for treatment. This therapy consists of an angiotensin converting enzyme inhibitor or angiotensin receptor blocker, a beta blocker, a loop diuretic when there is evidence of volume overload, and a mineralocorticoid receptor antagonist to improve cardiac contractility and cardiovascular outcomes. Calcium channel blocking drugs are not recommended as routine treatment for patients with heart failure with reduced ejection fraction or acute decompensated heart failure. The ACE inhibitors, enalapril and captopril, and aldosterone receptor antagonist, spironolactone, are safe to use postpartum and in breastfeeding patients given the small amount of medication that's excreted into the breast milk. Women presenting with acute peripartum cardiomyopathy require a coordinated cardiovascular and obstetric approach to optimize maternal and fetal well-being. The antepartum management of peripartum cardiomyopathy differs slightly from the postpartum management, as some standard heart failure drugs are contraindicated during pregnancy, such as ACE inhibitors and ARBs. One of the biggest challenges is to determine timing and mode of delivery. First and foremost, maternal stabilization is critical to achieve successful maternal and fetal outcomes. Immediate consultation with a cardiologist should be initiated if there is clinical concern for cardiomyopathy, even if the echocardiogram has not yet resulted. Timing of delivery is influenced by gestational age and may also be influenced by proximity to a facility with high risk obstetrics and obstetric anesthesiology experienced in cardiovascular disease. By nature of the definition, patients diagnosed with peripartum cardiomyopathy are generally in the late preterm or early term gestation, and there's often very little fetal benefit to continuing the pregnancy. Cunningham and colleagues proposed an algorithm for the management of peripartum cardiomyopathy, which serves as an excellent guideline and is very similar to the non-pregnant population with a few modifications. I have added several key points, including the importance of hemodynamic monitoring with telemetry and often an arterial line. A Swan-Ganz catheter is the gold standard for assessment of cardiac index, but has not been shown to overall improve mortality. Caution to avoid beta blockers in patients with acute decompensated heart failure and favor drugs like hydralazine and other vasodilators such as nitroglycerin or nitroprusside in these patients. Often, standard doses of magnesium are given in patients with overlapping features of preeclampsia, with special attention to fluid management, and one may also consider small doses of IV oxytocin, such as 3 to 6 units, to minimize additional IV fluids. The anesthetic management for a parturient with peripartum cardiomyopathy depends on the severity of the cardiomyopathy and patient's cardiopulmonary status. While vaginal delivery is the preferred method of delivery in a stable patient, there are several indications for immediate and emergent delivery via cesarean section, often under general anesthesia. Considerations for cesarean delivery include heart failure with an ejection fraction less than 20%, hemodynamic instability associated with cardiogenic shock and need for inotropic support or mechanical support, worsening pulmonary edema despite treatment, and impending respiratory failure. Obstetric anesthesiologists are a critical member of the team, and the anesthetic management should be based on the same principles used to manage any patient with severe cardiomyopathy. And these are reduce the preload and afterload, improve cardiac contractility, and avoid worsening pulmonary edema. In the hemodynamically stable patient that are a candidate for a vaginal delivery, neuraxial anesthesia has the benefit of minimizing positive pressure ventilation, which has an effect on right ventricular afterload. And using low-dose combined spinal epidural anesthesia, the sensory level can be achieved slowly in order to prevent hypotension. One of the most common complications associated with peripartum cardiomyopathy is venous thromboembolism. The incidence of thromboembolic disease is approximately 2 to 6% in patients with peripartum cardiomyopathy. It is recommended that this high-risk population receive prophylactic anticoagulation and in some cases therapeutic anticoagulation when the degree of left ventricular dysfunction is less than 30%, associated with arrhythmias such as atrial fibrillation, or findings of a left ventricular thrombus on cardiac imaging. Anticoagulation should be administered for at least 6 to 8 weeks postpartum. The safety of breastfeeding in patients with peripartum cardiomyopathy is not completely known. Concerns arise with regards to the association between prolactin and the pathogenesis of peripartum cardiomyopathy, and often the hemodynamic stress associated with lactation and the transfer of potentially unsafe medications into the breast milk. European guidelines for the management of cardiac disease in pregnancy discourage breastfeeding in those individuals with more severe cardiac dysfunction, such as NYHA functional class 3 or 4. Given the importance of breastfeeding in infant survival in developing nations, this prohibition of breastfeeding comes at a substantial cost and must be taken into consideration. In the investigators of pregnancy-associated cardiomyopathy, or the IPAC study, which prospectively studied 100 women with diagnosis of peripartum cardiomyopathy, recovery rates were similar among the 15% of women who continued to breastfeed compared to those who did not. There's been a great deal of discussion around the use of bromocriptine for the treatment of peripartum cardiomyopathy. The normal proteolytic degradation of prolactin generates a smaller 16 kilodalton prolactin molecule known as vasoinhibin, which prevents angiogenesis and promotes cellular apoptosis. This small prolactin molecule stimulates mRNA expression on endothelial cells, which drives endothelial cell injury, impairs cardiac myocyte metabolism, and results in myocardial dysfunction. Bromocriptine inhibits prolactin production through stimulation of the hypothalamic dopaminergic receptors. Several studies have demonstrated that bromocriptine, in combination with conventional heart failure therapy, benefits left ventricular ejection fraction and maternal morbidity and mortality in women with acute peripartum cardiomyopathy. Due to the limited sample size in these small studies, a systematic review was published in 2021 to evaluate the effectiveness of bromocriptine with goal-directed medical therapy in the treatment of peripartum cardiomyopathy. These studies that were included in the meta-analysis were a total of 6 and included 263 patients with 2 randomized control trials. Primary or secondary endpoints included left ventricular recovery with a left ventricular ejection fraction greater than 50% or improvement, which was defined as an increased ejection fraction greater than 10%, or NYHA functional class improvement of dyspnea by 1 class, from baseline, cardiac death, all-cause mortality, recurrent left ventricular dysfunction in subsequent pregnancies, and evidence of thromboembolism such as myocardial infarction, VTE, or cerebral vascular accident. The details of the 6 studies are shown in this table. The 2 randomized control trials had 20 and 96 patients respectively, and the longest duration of follow-up was 12 months. The baseline ejection fraction ranged from 22 to 37% in the intervention trials. The bromocriptine regimen varied from 2.5 milligrams twice a day for 2 weeks, followed by 2.5 milligrams daily for 4 weeks, compared to 2.5 to 5 milligrams daily for greater than 4 weeks. The conventional heart failure regimen included beta blocker, ACE inhibitor or ARB, mineralocorticoid receptor antagonist, and a diuretic. It's important to note that one of the randomized control trials used only an ACE inhibitor and a diuretic in the conventional heart failure treatment group. The authors concluded that the addition of bromocriptine to conventional goal-directed heart failure therapy enhanced left ventricular function at 6 and 12 months and decreased cardiovascular death in women presenting with this condition. The composite endpoint of poor outcome consisted of severely reduced ejection fraction less than 35%, NYHA functional class 3 or 4, or cardiovascular mortality after 6 months was lower in the study participants treated with bromocriptine and standard heart failure treatment compared to standard heart failure treatment alone. It's also important to note that these studies included in this review showed no thromboembolic events, including CVA, myocardial infarction, or VTE. The lack of this adverse finding is crucial because several studies have suggested that bromocriptine actually increases the risk of thromboembolism. Certainly, one of the biggest drawbacks of bromocriptine is the inhibition on lactation. The risk of major maternal adverse event is related to the severity of peripartum cardiomyopathy, with rates as high as 40 to 100% in women with severely reduced left ventricular ejection fraction less than 30%. Major maternal events include thromboembolism, cardiogenic shock, need for implantable cardiac defibrillator or permanent pacemaker, need for mechanical support with an intra-aortic balloon pump, veno-arterial ECMO, or a left ventricular assist device, or cardiac death. In the IPAC study, 6 women experienced 9 major cardiac events, including 4 deaths, 4 LVAD implantations, and 1 heart transplant. The likelihood of cardiac recovery with a left ventricular ejection fraction greater than 50% at 12 months may actually be much higher than we originally thought. Again, in the IPAC study, they showed a complete recovery rate as high as 72%. Alternatively, indicators for poor prognosis include an EF of less than 30% at the time of presentation, African American race, and a greater degree of left ventricular dilation. As stated previously, there are significant regional variations in mortality with worse outcomes in Haiti, Turkey, and South Africa, with mortality rates approaching 30%. The risk of recurrence in subsequent pregnancies is based on retrospective data, and small studies have compared women who have recovered left ventricular function from the index pregnancy to those that had persistently decreased function. The group with decreased function had higher mortality rates at 19% compared with 0%. All subsequent pregnancies were associated with a reduction in ventricular function from baseline. In a recent study from the Mayo Clinic, 25 women with peripartum cardiomyopathy, of whom 24 had recovered ventricular function from the index pregnancy, were followed through 33 live birth pregnancies. Although most of these cases had a decline in left ventricular function, only 21% had recurrent peripartum cardiomyopathy with an ejection fraction less than 45%, as seen in the pink boxes. The majority of these relapses were diagnosed in the postpartum period. And interestingly, no patients had a nadir ejection fraction as low in subsequent pregnancies as they did during the index pregnancy. As we end our discussion today, I would like to highlight the similarities between peripartum cardiomyopathy and COVID-19 related cardiomyopathy. Unfortunately, due to the COVID-19 pandemic, it may be more common to see patients present with similar features to both, posing a diagnostic dilemma. Cardiac complications associated with COVID-19 have been reported, and studies evaluating non-pregnant patients suggest that COVID-19 myocarditis may progress to dilated cardiomyopathy and heart failure. In a recent case report, a 28-year-old Gravida 2 Para 1 with no significant past medical history presented with severe shortness of breath and lower extremity swelling 24 hours after a spontaneous vaginal delivery. Chest X-ray showed cardiomegaly and bilateral infiltrates suggestive of pulmonary vascular congestion. The echocardiogram revealed a moderately dilated left ventricle with severe global hypokinesis and an ejection fraction of 22%. Cardiac MRI confirmed severe left ventricular dilation and severely impaired right and left ventricular function. COVID-19 testing returned positive. Unfortunately, if it was unclear if the patient developed myocarditis secondary to COVID-19, which may have resulted in heart failure, or had peripartum cardiomyopathy with an incidental finding of a COVID-19 infection. The patient was treated with loop diuretics, anticoagulation, and conventional therapy for COVID with remdesivir and dexamethasone. She had symptomatic improvement and was ultimately discharged home. The patient had multiple readmissions for decompensated heart failure and ultimately required a right and left ventricular assist devices and currently awaits orthotopic heart transplant. This case highlights challenges clinicians face differentiating non-respiratory cardiac complications of COVID-19 and peripartum cardiomyopathy. This also highlights the significantly increased morbidity associated with these diagnoses and the need for high clinical suspicion and early initiation of goal-directed therapy. When faced with a patient with symptoms of heart failure, remember to stay vigilant and have a high index of suspicion. A transthoracic echo is the gold standard for diagnosis, and I would recommend engaging cardiology, obstetricians, and anesthesiologists and intensivists with specific knowledge in cardiovascular disease in pregnancy as soon as possible. Implement goal-directed medical therapy, including diuresis, beta blockers, ACE inhibitors, aldosterone receptor antagonists, and anticoagulation. Peripartum cardiomyopathy is associated with an unacceptable rate of maternal adverse outcomes, and we must continue to investigate targeted therapies to improve the outcomes in those women whose probability of recovery on conventional therapy alone is diminished. Thank you for your attention this afternoon, and I look forward to our panel discussion.
Yeah, as this is a video recorded, and we are ahead of our time in the as per our schedule. I request Dr. Sunidhara to speak about peripartum cardiomyopathy management in our unit, so that we can take the questions as well at the end of her session. Over to Sunidhara.
Good evening. For the wonderful talk, the keynote speaker. So we have had a couple of recent admissions with peripartum cardiomyopathy. These patients will not be diagnosed and brought to us. So they come in a state of breathlessness, tachycardia, and respiratory distress. So it is important for us to evaluate the general physical condition of the patient initially, and then optimize and then manage accordingly. So when the patient comes with distress, it is very important to note how we evaluate this patient in form of physical examination, systemic examination, and then come to a differential diagnosis of why the patient is having this kind of dyspnea, and then accordingly treat her. So when a rate or respiratory rate of more than 30 with the accessory muscles involved, tachycardia, hypotension or hypertension. So these are the clinical presentations the patient comes in. The patient will be typically in a sitting position. They will not be able to lie down in a supine position, and they will typically present with a massive pedal edema on both the limbs. So this is a clinical presentation, and once the patient comes here, it's important for us to supplement oxygen, high flow oxygen with a face mask with a rebreathing bag. So face mask with rebreathing bag is supplement. It gives almost an FiO2 of 1. That is, we are giving 100% oxygen if we keep the flow rates at about 15 liters per minute. So this is the initial management till we know what exactly the oxygenation status of the patient is. Then we immediately connect her to all the vital monitoring such as heart rate, 5-lead ECG, non-invasive blood pressure monitor to know what exactly the hemodynamic status of the patient is. Now, once all this is monitored, we try to auscultate the lungs to see whether there is more of a wheeze or more of a crepitations to see the fluid status of the patient. Then we take an ABG to determine what are the partial pressures of oxygen, partial pressure of carbon dioxide, and what is the metabolic status of the patient in terms of pH and bicarbonate. So main thing what all of you have to know in deciphering the information in an ABG is what is the perfusion ratio, that is the PaO2 of the patient, that is the oxygen concentration of the arterial blood divided by the FiO2. FiO2 is fractional inspired concentration of the oxygen being delivered to the patient. So when we are giving oxygen through a rebreathing mask with 15 liters of oxygen, we consider it as an FiO2 of 1. So if the PaO2, for example, is around 80 on an FiO2 of 1, that means the PaO2 by FiO2 ratio would be almost approximately 80. So when in a normal individual, our PaO2 is around 100, and we breathe room air, which contains oxygen ratio of 21%. So if 100 by 21 would be 500. So the PaO2 FiO2 normally, which would have been 500, is only 80 in this particular patient. That's how we decipher. Anything less than 300 means the patient is hypoxic, means the patient is requiring more amount of oxygen to be delivered. So that is the indication where we decide oxygen therapy or invasive or non-invasive ventilation. When this ratio goes below 200, that is an indication for putting her on non-invasive ventilation, that is mechanically delivering a forced oxygen to the lungs, because the lungs are not able to deliver that oxygen on its own. Once the ABG values are deciphered and treatment given, then we go to the volume assessment. A volume assessment can be done by clinical examination as well as the ultrasonography, of the IVC. So what we do in our unit is with an ultrasound, we see the IVC, how much it is dilated and what is the collapsibility index with inspiration and expiration, and accordingly determine whether the patient requires more fluid boluses or it is fluid overloaded. Then accordingly the treatment can be given. Usually these patients will be fluid overloaded, and so a diuretic shot of 1 to 2 mg or per kg of Lasix, that is furosemide, can be given to decompress the lungs which is filled with fluid. That's because of the failure. Now, there is a systolic dysfunction in peripartum cardiomyopathy. So what exactly happens is the left ventricle is not able to pump the cardiac output into the aorta, which again supplies to the various parts of the body. So because there is a left ventricular dysfunction, it is important to improve the contractility. To improve the contractility, we administer digoxin and an inotropic agent, that is dopamine. It is important to limit the fluid input to this patient, at the same time increase the inotropic support. So this balance is very important, and at the same time we can deliver an, if the patient's hemodynamic status is optimized and he is not hypotensive, then we can give a arteriolar vasodilator to reduce the systemic vascular resistance so that the output can be increased in the form of either hydralazine or NTG, that is if the hemodynamic status is fine. So this is what we do, and considering the non-invasive or the invasive ventilation, we administer CPAP or BiPAP at a higher inspiratory pressures and higher FiO2s, and with serial ABGs and serial X-rays, we determine to de-escalate the support systems to the respiratory tract. So this is what we do.
So I think there's some delay.
You're muted, sir.
Sorry. No, I'm not. Am I not audible?
You're not audible, sir.
I don't.
We can hear you, sir.
We can hear you, sir.
Okay. So before Dr. Allison joins us, I just thought we could discuss a little bit. I just wanted to ask Dr. Bhavani, when do you evaluate, I mean, at what stage in pregnancy do you flag these patients? When do your obstetricians refer these patients to you with a suspicion of, I mean, if someone is breathless, and how would you proceed? Do they directly refer to a physician or do they refer to you and you then decide whether it should go to a physician?
So you can all hear me, right?
Yes.
Yeah. So the way we work is we have actually, I think every twice monthly, a cardiac OB meeting, and which is attended by the obstetricians, particularly Dr. Langford. And also we have a cardiologist who is actually, whose interest is obstetrics. So they actually screen the patients and present to us when we are at the meeting. And this happens first time they see the patient. I mean, you know, whenever they are, I mean, not 10 weeks or 12 weeks, but at least if someone is very critical, of course, they bring as soon as they get to know of the patients. So usually these patients are discussed almost every 2 weeks on their follow-up. And if we decide our plan that, you know, they need to be optimized and or some sort of a therapy, sometimes, you know, using anticoagulants, not using anticoagulants, etc. And then they get referred to us certainly. Now, what I tell them is, if someone goes through the 28 weeks of pregnancy, 28 to 30 weeks of pregnancy without short of breath, that means they are through to their term, because that is the time the cardiovascular system has got the maximum overload with cardiac output. So they refer these cases, you know, to us as appropriately between around 28 to 36 weeks. But most of them are seen if for some reason the patient comes off, you know, like this is a high risk referral center. So anywhere from the state of Maryland, the cases can be referred here. Immediately they get in touch with us, particularly Dr. Langford will stop me and say, I have this patient, this is what it is, and our cardiologist has said this, and what do you think? And I give them my management.
So I understood what you're saying. What I wanted to bring across was, if there is, when an obstetrician is seeing the patient and the patient complains of breathlessness, the first thought which comes to the obstetrician is not necessarily cardiomyopathy. So they might be thinking it is just, a large pregnancy or twins or, whatever. So what should trigger them to refer? And so in our setup in Rainbow, we tell them to refer anything abnormal to the anesthesia team. Then we ask the appropriate questions to the patient and refer them onward for further evaluation, either a physician or a cardiologist as we think appropriate. So just wanted to know how that works with you guys.
No, I don't think that they refer all cases of, short. See, anyone who is obviously short of breath has got a history of some sort of a cardiac, they will certainly refer. But every case of a problem, which I'll present one of the cases in my lecture, and I will tell you how I also could not come up to a conclusion in that case that something was wrong with her. But the thing is, I don't think they refer just because someone has got slight shortness of breath or maybe a little bit of asthma or something, bronchodilators. They try that. If that doesn't resolve, then of course the next step comes. But I don't think they have any standing rule like that.
Then just.
But I think your setup is good, which you are catching up. What is your yield from this? Suppose if you have to propagate to your colleagues elsewhere, what is the yield of this referral service? That means everyone who is short of breath is being referred to you, but what is the yield? How much were there was problems and how many were not problematic?
I don't really think we have the statistics, but I think basically because our obstetricians are quite busy, and especially in smaller setups, they are quite busy with their work, and they don't focus much on the medical side of patient management. And we work as a team where we chip in with the medical support and the peripartum. You can say anesthesiologists who work regularly in obstetrics, as you're aware with your Indian colleagues, is we are like the peripartum physicians. So we sort of, support, and when we think a case is beyond us, we involve. And nowadays, our youngsters, especially Dr. Sunidara and others, they use a lot of ultrasound, and they themselves, can scan and pick up basic problems. So the real need to refer is, coming down and down, at least as long as you can pick up what the case is.
Yeah, but one thing is certain, that every obstetrician, when they find out something abnormal, and if they cannot figure out, they must have some system of referring at least to a general physician or their own physician to figure out what is happening.
Dr. Shruti, just comment on this. What do you want to say?
Yeah, yes, sir. Like generally we do refer because these days what we are, yes, as you said, there is a busy OP going on. So whenever we see there is an obese patient and twin patient complaining of breathlessness, or a BP patient coming with breathlessness, we would like another person also to examine her so that we don't miss things. And then appropriate echo will be done. And we have Sunidara who just comes to the labor board and then does a proper echo, and she looks at the inferior vena cava, IVC also. And then we are little safe till our cardiologist comes into our unit. So that's how we feel more safe. So, sir, I have two questions, if sir or you can answer.
I just want to add one point here to all the obstetricians in the group. We have a focused medical history scoring system we have put up in our department, which has small symptoms with grading like orthopnea, dyspnea on exertion, unexplained cough, swelling of the lower extremities, excessive weight gain during the last month of pregnancy, palpitation. So they are scored as 0, 1, and 2. And if the scoring is 0 to 2, that means they are at low risk for any kind of respiratory distress or cardiomyopathy. If they are at 3 to 4, it is a mild risk and they have to be referred to an anesthesiologist or a cardiologist to do an echocardiogram and rule out if they are in failure. But if it is anything more than 5, definitely it is a high risk and has to be referred to a cardiologist along with an anesthesiologist to optimize the patient. So this is what we follow in the department.
Okay. No, I think that is an excellent, plan. For example, I will tell you, recently I reviewed one case where she was 34 weeks or 35 weeks twin pregnancy. And, every twin pregnancy, slightly obese, will have some sort of breath. Nothing really significant. She was sitting well. However, as soon as they gave the renal anesthesia, patient actually had the pulmonary edema. And at the time they found that it was, she did have some sort of a cardiomyopathy. So you're right, but sometimes it is very difficult when I will highlight in my lecture too. And, but I think it is a good plan to have.
Thank you, Sunitara. So I think Dr. Allison also has joined now. If she can answer these questions which are posed by our delegates, they are asking that, could you elaborate the dose of bromocriptine in peripartum cardiomyopathy? Dr. Allison, if you can answer this.
Sure. Good morning. Sorry for joining a little bit late. The several studies that I looked at, there were a couple different treatment regimens. The most common ones that I came across were 2.5 milligrams BID or twice a day for at least 2 weeks, followed by 2.5 milligrams daily for the remaining 2 weeks, for a total of at least 4 weeks of treatment. That was the most common one I found. The other was 5 milligrams daily for 4 weeks, but that seemed to be the duration of treatment was generally 4 weeks.
But we heard there is, before that, we enjoyed your recorded video because of your time constraint. I think we had a recorded video, but I think it was very clear. I just heard that there can be an increased risk of thrombosis when you go with the bromocriptine. Is it true?
So there is a recommendation when you're giving bromocriptine to make sure that they're on anticoagulation. But in several of the studies and in the meta-analysis that pulled all of the studies on bromocriptine, the 6 studies, they actually didn't show any increased incidence of thromboembolism in the group that was on bromocriptine and the standard heart failure therapy. So I think most commonly these patients are anticoagulated, but I think it's hard to make a definitive statement that bromocriptine itself is going to increase the risk of VTE.
Okay, thank you. Maitri, we can move on to the next session, please.
Yes, ma'am. Now to our second panel discussion about the very core and essence of this CME, high-risk pregnancies. The moderator for this session is Dr. Subramaniam, founder, director of Axon Anesthesia. He is an executive body member of Association of Obstetrics, Anesthesiology, and Indian Association of Physician Assistants. Besides being an absolute and thorough professional, he's also a phenomenal human being. I request Dr. Subramaniam to introduce Dr. Bhavani Shankar, our international faculty and first panel member.
Thank you, everybody. It's a real pleasure to introduce Dr. Bhavani. Our association goes back, I think, over 20 years now. I first met him when I was in US in 99, 2000, when he was working in Brigham and Women's. And ever since, he's been coming over to India to address our conferences and lectures. He's an MBBS graduate from JIPMER, Pondicherry, and then he did his anesthesia in Chennai. And he went to West Indies before going on to Harvard, where he did his residency, fellowship, and rose to become an associate professor there. And then a professor. He's now moved as the head of High Risk Obstetrics unit in University of Maryland. And he's a very passionate, committed obstetric anesthesiologist. His other interests are N-tidal carbon dioxide. He's very prolific in publication. I mean, we'll be very embarrassed with the amount of volume we have. We hardly have publications in India, but he's a very good, researcher. And he's very down-to-earth person. Very, very warm, affectionate, friendly. And he actually handholds a lot of obstetric anesthesiologists in India. He is very committed to improving the standards of obstetric anesthesia in India. Welcome, Dr. Bhavani. Thank you very much. We can't hear you, Mike.
Our next panel member for today is Dr. Allison. Ma'am, I take great pride in welcoming you to our CME. We're extremely overwhelmed to have you participate in this webinar, and thank you for taking time out and being a part of it. Our next panel member is Dr. Sunidara. She's a senior consultant at Axon Obstetric and Pediatric Anesthesia and Intensive Care. She's synonymous with maternal ICU care at BirthRight Banjara. She's been the very foundation for our team when it comes to high-risk obstetric care. Welcome, ma'am.
Thank you.
Our last panelist for this session is Dr. Jyotsna. She's a consultant on obstetric and gynecology at our Kondapur facility and is experienced in minimal invasive gynecological surgery and takes keen interest in dealing with high-risk pregnancies. Sir, over to you, sir, now.
Yeah, so just want my screen sharing. Want to check if this is working before we can. Can you see my screen, please?
Not yet, sir. Yeah, we can see your screen, sir, but not the presentation.
Yeah, one moment. Now?
Yes, sir. If you can just put in slide mode.
Yeah. Okay. So before I begin, thanks for all the panelists. So in essence, we have two anesthesiologists, one Dr. Sunidara from India and one Dr. Bhavani Shankar from US. We have two gynecologists, obstetricians, gynecologists, Dr. Jyotsna from India and Dr. Alison Langford from US. So it should be very interesting to bring across cultural divide and the way each institution goes about managing these. So we've just picked 4 different scenarios. I mean, some based on real cases, some are made up. So let's, and we encourage audience to type their questions in so that we can get, responses as we go forward. Now, before I begin this, I just want to highlight, it's not that you people don't know, but why we are having this discussion is to try and decrease the maternal mortality. And we are all aware that the developing countries have a lot more maternal mortality than the advanced Western countries like America and Europe. And if you see the maternal mortality in India was 370, this was a 2000 figure, that is 370 mothers are dying for every 100,000 live births. And I should say the government of India has done a phenomenal job and trying to follow the Millennium Development Goals. And now in 2017, it is about 145 across the country. But if you take state-wise, our state, the former combined Andhra and Telangana, the maternal mortality is as low as 65. I mean, though we should feel happy about it, we are still 10 times higher than UK or US, for example. So we are getting there, but we have a lot more to do. And our philosophy is that every maternal mortality is potentially preventable, which means ideally you should have either nil or very, something below 10, which is acceptable. So we still have some work to do. And most of these maternal deaths, if you analyze, you'll see that something went wrong somewhere. Either the referral was delayed or the management was bad. And if you could get all these right, we can all together reduce this mortality even further. And we must thank our UK colleagues for putting us on the right track. They were the first to initiate the maternal audit on maternal deaths and suggest ways to improve it. And I think many other countries have taken this forward. So with that, and the causes of maternal mortality are different in different countries. Some of the causes may be specific to India. So now we'll just go forward with some of the cases. So this is a patient who is 30-year-old parturient. She was gravida 3 with 2 prior abortions, and she came at 24 weeks gestation. And she was admitted, something similar what we were speaking till now, shortness of breath since 15 days for evaluation and management. Her breathlessness progressed from NIHA grade 2 to grade 4 in the last 2 days with palpitation, orthopnea, PND, and pedal edema. So just, Sunidara, elaborate what is NIHA and why is it important?
Yeah. So NIHA is New York Heart Association classification to just brief us about how severe the cardiac illness is or the breathlessness is. So class 1 would be completely normal, even with a stressful sport activity. They do not have any kind of cardiac symptoms such as breathlessness, short palpitations, angina, pain, or pedal edema, PND, that is paroxysmal nocturnal dyspnea or orthopnea on lying down. Class 2 would be, they would be having these kind of symptoms more than the normal activity. Class 3 would be, they will have these symptoms when they are doing normal physical activities. Normal physical activities would be to walk on a level ground for maybe half a kilometer, or do regular activities like taking bath and doing normal home activities. Class 4, all these symptoms would be present even at rest.
So this is important to know change in status of a patient from one class to the other. So our patient came to us with a blood pressure of 109/73 and a pulse of 110 to 115 and a respiratory rate of 34 to 37. And the saturation on room air was 88%. And when oxygen was instituted, it was 92%. Now, just again, I'm referring this to you, Dr. Sunindara. How do we know? I mean, let's say a nurse first received this patient or a junior doctor in obstetrics. They may or may not realize that these values are abnormal. So how is there a system where they can pick this up and say that, they flag it as something is wrong?
Yeah, they have these early warning signs and symptoms. We have a Muse chart, that is a maternal warning system scoring. We do it regularly in our hospital, which records different values in the form of temperature, heart rate, systolic and diastolic blood pressure, the neural response, proteinuria, and the pain score, whether the patient is having nausea, vomiting. So depending on these color coding systems, white being normal, yellow being slightly severe, and orange or amber being very severe. So any one red or orange with two yellows at one single point of time means the patient has to be alerted to a higher, more intervention. Maybe the sister can call for help for a anesthesia doctor.
Dr. Langford, do you do this routinely in your unit? Is the Muse chart followed or your own version of it?
We don't have anything established set in place. There's certainly a lot of literature about using these maternal early warning signs, and I think it's great. We haven't incorporated it into our electronic medical record as of yet.
Okay. So what would be your differential diagnosis at this stage, and how would you proceed, Dr. Langford?
So when a patient presents like this, I certainly would think of a primary either cardiovascular or respiratory condition. So certainly, as we discussed, cardiomyopathy would be on the differential, whether it would be like I said, a primary respiratory issue. So would they have a pneumonia? Certainly we could keep in mind pulmonary embolism, that's leading to shortness of breath and tachycardia. Is there concern for infection, sepsis, that leading to an ARDS-like picture? Those are kind of the initial things that come to mind.
Okay. So, Dr. Bhavani, would you like to add anything more to that? And how would you proceed from this stage?
Yeah, actually, I mean, one thing I would like to add is somewhere here, fetal heart rate has to be monitored. We need to figure out what is happening to this fetus, though, because
Right.
that will dictate our management. Because sometimes it could be a stat, even doing without anything.
Right.
If there is a fetal bradycardia. Now, actually, now we just need to do some sort of labs to rule out any preeclampsia causing the shortness of breath, and the usual chest X-ray and also an echo. This will, as Dr. Allison has pointed out, these diagnostic modalities will give us an idea, at least to pinpoint to a certain extent what is the cause.
So can I just stop you there? You said chest X-ray. There seems to be a lot of fear about doing a chest X-ray in an obstetric patient in our setup here. So since you mentioned it yourself, I'd like to ask, what is your take on, and Dr. Allison as well, would you freely, get a chest X-ray done, or you think 100 times before you do it? What is the way to reassure someone that it's safe? A single
Absolutely not. Actually, X-rays are done very routinely, particularly now we have substantial experience with COVID now. The COVID patients get X-rays almost, in fact, we were just evaluating the data recently. Sometimes they get every day, sometimes at least 1 to 4 days. So there's no problem at all. And if there is and they also get a spiral CT also in order to rule out pulmonary embolus during pregnancy. Alison, you can add.
Yeah, I agree. I mean, the risk of radiation is pretty minimal, especially if we're able to shield the abdomen. So I think the amount of information you can gain from a bedside chest X-ray is so valuable that I generally don't hesitate to get a chest X-ray in these patients.
Dr. Jyotsna, would you like to just comment? Because I think we have a lot of reluctance in India to get a chest X-ray done, though I keep saying that chest X-ray is the cheapest and simplest investigation, which can point us to what kind of problem is going on. I mean, in this instance, for example, you can either see a cardiomegaly or some lung opacities or a patch, or, even if, like in a peripheral center, you may not have an echo or anything, but just a simple X-ray, almost every setup will have.
Yes, sir. To put the perspective, I have patients who ask me if too many ultrasounds are harmful to the patient. So coming from that, if we have to tell them that you have to take a chest X-ray, the mother and the father are going to panic. So I think it's more than deciding whether to do the chest X-ray or not. It's about how we counsel the patient. I think there is no doubt about the fact that the chest X-ray is not harmful to the baby. I think it's about how we counsel the mother and the father.
So what after these tests, what do we, let's just see what was done. A screening 2D echocardiogram was done by a junior physician on site, and they found that the ejection fraction was 30% in this patient. There was global hypokinesia and severe left ventricular dysfunction. So from this stage, I think Dr. Sunidhara, you had highlighted earlier, just again mention what way you want to manage this patient.
So since there was global hypokinesia, we would take the diagnosis as peripartum cardiomyopathy with this picture. So we supplement oxygen, go ahead with ABG to see the PaO2s and determine what level of oxygen supplementation or support systems the patient requires. And if they require ventilation, we would go ahead with non-invasive ventilation at the beginning. And medical therapy would be fluid restriction to titrate the fluids according to the volume status determined by the IVC volume in ultrasound. And medical management would be to increase inotrope, the contractility of the patient with digoxin to remove the fluid overload by diuretics, and decrease the heart rate by giving a beta blockers.
Okay, so just as a message to others who are listening, when I think monitoring urine output is very important in these patients, and to start with, the urometer, which can monitor an hourly urine output, is much better. And Dr. Bhavani, could you tell what is the advantage, for the sake of our obstetricians, why just an oxygen is not sufficient, and why should a CPAP be given in these patients?
Well, because there is some amount of either ovate pulmonary edema or subclinical pulmonary edema, or what is called the interstitial pulmonary edema, which actually decreases the FRC. And actually pregnancy already is associated with decreased FRC. What I mean by FRC is the lung is slightly, the alveoli are compressed by the growing fetus because of the shear pressure. So CPAP actually helps to stent open these alveoli and improve the oxygenation, and also drive the Starling's equation in preventing probably more interstitial pulmonary edema in this case.
Okay, Dr. Langford, anything you can add? There's some concern some people have in doing a CPAP on pregnant patients. Some say that it's not safe and you should intubate rather than do a CPAP, though we've been doing CPAP from a very long time because it's more acceptable to the patients and, it's much less sedatives and other things you need than intubation. But what's your experience? What do you want to add on this?
Well, I agree completely that I think, using non-invasive ventilation such as CPAP can often sometimes even potentially prevent these patients from having to be intubated. We certainly recognize that CPAP and, afterload reduction is improvement in pulmonary edema, and again, can prevent these patients from having to be intubated. Certainly there is sometimes concern in pregnant patients with relaxation of that lower esophageal sphincter and increased risk of vomiting. But I think as long as the patient is alert and not having any confusion and doesn't have any overt contraindications for non-invasive ventilation, then CPAP is an excellent option.
Okay, thank you. So just if you recollect what happened, a junior physician on site did the echo, which is not the most accurate probably. It was a screening echo. So the next morning we had a cardiologist to come in and do a proper cardiac echo. And to all our surprise, he found a bicuspid aortic valve. And it was actually a case of a severe aortic stenosis with some aortic regurgitation. And there was also left ventricular dysfunction because probably this must have been long-standing. So in this scenario, how would we now proceed, Dr. Langford? Then I'll ask Dr. Our colleague from here, Jyotsna, also to give the obstetric management. Dr. Langford, please proceed.
Sure. So, in a patient with severe aortic stenosis, they have a fixed cardiac output. So the increased cardiac output and volume expansion can be very troublesome in pregnancy, as we're seeing with this patient. So, I think the kind of fundamentals for treatment of aortic stenosis is certainly reducing the afterload, and improving the contractility. So, same thing, similarly, we use diuresis in order to reduce the volume. We would use afterload reduction agents. You could use hydralazine. This patient, you have to be cautious again with beta blockers and decompensated heart failure, but you could use those if, otherwise she remains hemodynamically stable. And the other thing is improving the contractility. So we had alluded to using inotropic support, so something like digoxin, as we had talked about, or even sometimes in the acute setting, we'll use small doses of epinephrine or even dobutamine to improve contractility. And then I think having a multidisciplinary discussion with obstetric anesthesiology and cardiology to determine the ultimate management, and this patient will ultimately likely need a aortic valve replacement, which would be done after delivery.
So, Dr. Jyotsna, now that we know the diagnosis, how long would you treat this patient medically, and when do you think would be the right time? I mean, is it 28 weeks, longer? How do you balance the mother and child's, outcomes?
So I think at the first instance, at the time of diagnosis, we need to know the status of the fetus. And if the growth and the Dopplers if there's no fetal indication to expedite delivery, I think the management of the patient for the cardiac condition takes a priority with a regular antepartum fetal surveillance plan put into place. And we can take the pregnancy forward till 34 weeks, certainly. Or if the patient worsens in between during our monitoring phase, we might have to take the call for delivery. But there is no emergent obstetric indication to deliver this lady as of now.
Okay, perfect. So then what happened was, as we discussed, she was put on CPAP for 2 full days. Mask was removed only occasionally to make her breathe or eat, to talk or eat, and strict fluid balance was maintained, the drugs were given, and electrolytes and other things were monitored. So 6 days later, the repeat ejection fraction had slightly picked up, and the patient was now comfortable on room air and was asked to go home and come for repeat monitoring. So Dr. Langford, this kind of patient, now she was 24 weeks. If you send her home, what would be your advice? How frequently should she come back to you?
That's a tough question. I think I might have a hard time sending this patient home with severe aortic stenosis. I think pending resource limitations, this might be someone I would actually keep in the hospital with really close surveillance, because she's at really high risk for, again, having multiple readmissions for decompensated heart failure. She's at really high risk for arrhythmias. So if it was possible, if I sent her home, I certainly would be seeing her at least weekly, if not hopefully seeing cardiology once a week and the OB team once a week. So she at least had someone seeing her twice weekly.
Yeah. Do you want to add something, Dr. Bhavani?
No, I think it is as Dr. Langford said, I think it is actually the comfort level. And the question here is, it also depends upon how quickly the patient can be mobilized to the hospital too, particularly in a setup, for example, if the patient comes from a long distance and then you send them home, to come back is also, a problem. Yeah. So it's a judgment call, I think, there, and it's probably.
No, I agree with you. In retrospect, this patient should have been kept in the hospital. She went home and he came back. But just a few questions. Where do we plan this delivery? Dr. Jyotsna, maybe you could, and Dr. Sunidhara, this could be, between two of you. Can you take this? Should she have been managed further in a specialist cardiac unit, or can a hospital like Rainbow take care? And would you plan a normal delivery or an elective C-section?
Sir, if she had remained stable with the previous echo findings, and we managed to prolong her pregnancy further without any more incidents, I think we can manage at our center, but it's always preferable to have a specialist cardiac unit for such a patient who's had one acute episode.
Sunidhara, anything you want to add?
Yeah, we can manage this patient in our unit, provided we have a cardiologist who can come in at any time to on an emergency basis. So otherwise, we'll have to round the clock keep her under monitoring, and whenever she decompensates, we'll have to take a call on how to deliver her. Coming to normal delivery or cesarean section, especially this patient with such a high risk factors involved, it would be better to go ahead with a planned elective cesarean section if it is not an emergency obstetric indication or a fetal indication.
Okay, so we won't go into the specifics of the anesthetic technique now. We'll go on to the second case in the interest of time and ability to just see a cross section of different cases. So this patient arrived at 11 p.m. to us, which is quite common in the way sick patients arrive. She was a 29-weeker, primey, aged 26 years, had headache and blurring of vision since morning. And her primary doctor had given her 2 loading doses of magnesium sulfate, which is just for clarification to our overseas doctors, the loading dose refers to 5 grams of magnesium in each buttock. And she arrived with a blood pressure of 180 over 120. How do we proceed, Dr. Jyotsna?
At the outset, this appears like a case of preeclampsia, severe preeclampsia. So we would first get an IV access, assess the fetal status, take the samples for lab, and we also test for the magnesium levels because she's already received 10 grams of magnesium sulfate, although I would have preferred that she received the IV dose of 4 grams and then put on a infusion. That would have been the ideal situation. But now that she's come to us after receiving, I think we'll assess the maternal condition first. And this appears like an impending eclampsia. So we have to plan for delivery.
Okay. So, Dr. Langford, what labs would you want? How would you proceed further?
I think getting our standard preeclampsia labs with a complete blood count, a comprehensive metabolic panel, LDH, uric acid, certainly a urine analysis so we can assess the protein in the urine. The other thing that would certainly the only other thing I have to add for when initially evaluating the patient and after we obtain either IV access or using oral agents is to administer something pretty quickly upon arrival just to get the blood pressure down because it was elevated in the 180s.
Sure. Dr. Bhavani Shankar, anything more on this?
No, I will also look at the bicarb values in this patient. Because if they are acidotic for some reason, then the ongoing we may have difficulty in controlling the blood pressures, and also they may become hypotensive too.
Okay. So since the decision was taken that she's for, very early delivery, the team sent for cross match of blood and other products and platelets as well because her platelet count was low. This is something I think is now quite standard. Dr. Sunidhara, can you just elaborate what platelet count would you accept before taking up this case for surgery?
Yeah, so for an operative procedure, we would like minimum of 50,000 of platelets, but we would like to have a SDP or an equivalent dose of RDPs to be transfused and then taken up for surgery. Within half an hour of the transfusion, we can go ahead and have the section done.
So, Dr. Bhavani, would you give platelets and do a spinal for this patient, or would you prefer a general anesthetic?
If I give the platelets, I'll probably, if they come above 70,000, I probably may prefer regional in this, a single shot, small, very thin needle. The reason being that we can avoid this blood pressure fluctuations and management becomes easy. But that is something which we have to see how much of platelets will bring the platelets over 70,000 or so. And this is only if other coagulation parameters are normal.
Okay, fair enough. So in this case, I think because of the imminent eclampsia concern, the decision was taken to do a general anesthetic because if you had to give platelets, you had to again go and get the numbers done, and probably the team didn't want to wait. In this particular case I'm talking about. So she was catheterized, she had oliguria and very low urine output, and she went into the operation theater. So Dr. Sunidhara, just I want to show some of this. See, this is how she was when she was catheterized. You can see it is almost like blood in the urine and very little urine. And she was taken into the urine. So can you, Sunidhara, elaborate what monitoring should be put on to this patient?
I'd like to have a 5-lead ECG monitor along with ST segment monitoring, non-invasive and an invasive blood pressures to see what fluctuations happen during my laryngoscopy and intubation, and mandatory monitors like saturation, ATCO2 and a temperature monitor on her. Urine output monitoring would be done throughout the surgical time. And I would like to go ahead with a smooth rapid sequence induction with propofol titrated doses because I don't want to have a sudden fall in the blood pressure also. And along with that, a rapid sequence dose of rocuronium, smooth intubation, smaller size tube, and check bilateral air entry. I would like to give pre-induction dose of lignocaine to blunt the laryngoscopy response too.
Dr. Bhavani, anything you would particularly prefer if general anesthesia has to be done in these kind of patients? Her diastolic was around 110 when we started.
Yeah, I think, as she said, probably metoprolol is okay. And some clinicians also use a little bit of fentanyl at induction. And then just tell the neonatologist that, we did do some fentanyl for induction. The idea here is just to blunt the, intubation response.
Okay. So just, the case went ahead, delivery was done, and you can see all the monitors. Sunidhara, you didn't mention the entitled carbon dioxide. Of course, that's mandatory for any general anesthetic. So I just wanted Dr. Bhavani to comment on this. This is the recording periodically. You can see this is every 3 minutes we were getting the blood pressure. So tell me, was this reasonable, or something better could have been done?
I mean, it all depends upon how aggressively we are going to control. Probably this case, if it is that severe, probably an A line would have been better, and then started off with some sort of an intravenous either nitroglycerine or nicardipine infusions. Normally, sometimes actually here Dr. Langford does put, and she calls us also sometimes to put an A line, particularly to use these infusions, and that would probably give us a little better indication to control the blood pressure a little more effectively.
Sure. But one other principle in this, I think we all agree, is we shouldn't drop the blood pressure suddenly, because they're used to a much higher diastolic and perfusion pressure, at least until the deliveries are done. Yeah. So what other antihypertensives would you use, Dr. Langford? You did mention nifedipine and metoprolol. What else would you use?
Yeah, and it just, if I can make one comment about the intraoperative blood pressures as well, I think, we're hesitant to drop the patients too low, especially if we're unclear about the operative blood loss and how that may proceed, especially in someone that has thrombocytopenia, and we worry about additional blood loss. We want to be really cautious with using agents, because her blood pressure may fall in the OR, depending again on the blood loss. So some of the other agents that we use, so we certainly use IV labetalol, we use IV hydralazine. If we're doing an infusion, just as Dr. Kodali said, I often use cardine or clovidipine. We rarely use nitroglycerin, but it's certainly available. And I see that we have clonidine there. Again, that's not something that I'll commonly use just because of the rebound effect. And there's other agents that we prefer, but those are the most common things that we use.
Okay. So we'll just quickly talk about fluid management. She had about 2 liters of fluid given, and her urine output was still low. Dr. Sunidhara, how would we proceed with managing?
Yeah, at this point, probably we should look at the volume status again to see whether the preload is adequate or not. If it is not, then probably we can give about 200 to 300 ml of crystalloid bolus to bring up the pre-renal volume, and then look at the response in the next half an hour to 1 hour at the urine output. If it is still low, once the volume is adequate, then we can give a dose of Lasix to stimulate the kidney.
So, Dr. Bhavani, again, because this is always a dilemma when a patient is known preeclamptic and severe preeclampsia, people are concerned about giving fluid, which I think Sunidhara pointed out that they are very often intravascularly depleted. So how do you actually determine when and how to optimize fluid before thinking of giving Lasix, which may be detrimental if you give it before giving basic volume to the patient?
Yeah. So here 2 things we can do, and one is you can actually give boluses of fluid. Say you give 500, see what is the response if there is. So you can give another 500 and you can see there is a response. If there is no response at all, sometimes it is good to use even non-invasive or invasive stroke volume determination. Previously, we used to use central line. Actually, nowadays, very rare to put central lines in these cases. Stroke volume is a much better criteria because it gives you how the heart is pumping, and also we can also determine SVR indirectly. So that will tell us whether we have to use inodilators, particularly in a very severe form of preeclampsia. That helps. Now, generally, I follow the a push and pull mechanism. That means I may give albumin in these patients because that the oncotic pressure in preeclampsia is decreased. After giving albumin, then I gave Lasix in these patients. And sometimes that actually helps this process. And then people are divided on this approach. Even the literature is divided on the approach. And so that is what I would do in these cases.
Fair enough. So we do strict input-output charting and 6-hourly labs. So gradually the patients, the urine color started improving. I just wanted to add a quick note for our obstetric colleagues. I hear a common comment. Initially, Jyotsna said, we should have given an IV infusion of Maxelf. So I'm just showing on the left screen how we give the IV magnesium. We add 20 grams in 500 ml, and 25 ml would then make up 1 gram of magnesium. So yes, you do have to buy an infusion pump to do that, but I think it's not very expensive. It's about 30,000 rupees or something like that. And even if you don't have that, you have these disposable devices. This is called a flow meter, where you have this rotary where you can just turn to set how many ml per hour you want to give. And this is a pediatric infusion set called a pediatric burette. So there are devices even here at low cost where you can still give IV magnesium and avoid your toxicity. So I think even the peripheral centers should stop giving the intramuscular magnesium because the absorption is erratic and we don't know how much blood levels it reaches. If you have the facility and infrastructure, it's better to do the IV infusion. And this patient settled. The nitroglycerin infusion was given as was described earlier. So just one comment, Dr. Jyotsna, just look at the labs here, the serial labs. What is it telling you, and has it covered everything? Have you investigated more, less? What more do you want done?
I think we've investigated once in 6 hours, which is what we normally advise also. At least for the first 24 hours, we'll do it once in 6 hours. And then 24th hourly, we can monitor. I can see that the total WBC count is falling, but the hemoglobin is also falling, which is expected that some amount of dilution plus blood loss has happened after the delivery. And platelets are falling according to that chart, but I think initially the platelets were transfused, so we'll have to take that into account.
So what gives you, Dr. Langford, what actual values, what do you look at to say that the patient is turning around rather than further deteriorating?
Certainly looking at the platelet count, showing that her platelets are improving. I look at the liver function enzymes. I certainly look at the creatinine too, especially in someone that initially had very low urine output if we're concerned about an acute kidney injury. And one of the things I think I'm just having a hard time seeing on here is I look at the bicarb as well to see if the patient is improving, because certain if she had low urine output or creatinine was rising, I start to look to see if there's any indications that she would need some sort of renal replacement therapy or dialysis. But overall, I would expect, and maybe not an initial improvement, sometimes it takes 48 hours to see those labs start to trend in the correct direction.
So just to clarify, we don't have a blood bicarbonate. I mean, it's not common, at least I haven't checked, but we get a bicarb only when you do an ABG here. So if you do an ABG, you get the bicarb and lactate and whatever. So that's not part of the normal blood panel. At least in India, it's not common.
Do you get CO2?
Sorry?
Do you get CO2? The lab actually gives you the CO2 level.
No.
They don't give. Okay.
It's only part of the ABG sample. In the blood gas analyzer, you get all this.
Okay, here we get CO2, and that's why that gives us an indirect estimation of bicarb actually.
Okay. So just I wanted to ask, you already said that you don't monitor CVP anymore and you use non-invasive methods. Any role for it, Sunidhara?
When we have a non-invasive way to assess the fluid status, there's no need for us to go ahead with an invasive monitoring like CVP.
Okay. And finally, when would you think of dialysis, Dr. Langford, in this patient?
In someone that has significant volume overload, is unable to maintain or manage her own volume status, if there's concerns for refractory acidosis, any electrolyte abnormalities, those would be the big things. Generally, we don't see it. Uremia is pretty low in our indication for it, but I think in this patient, those would be the most common indications.
Okay, thank you. I think we'll just move over to the next case. So this case was a 28-year-old primary gravida who came with 37 weeks gestation, was being induced for labor. This actually happened in our unit recently. She had fresh grape juice. We allow liquids during labor. We don't keep them strictly fasting. So immediately thereafter, she had tachycardia, blotches on the skin, low blood pressure, and tachypnea. So what do you think was happening, Dr. Bhavani?
I think this looks like more like an anaphylaxis, I think, here, because tachycardia, skin rashes and blotches, low blood pressure, tachypnea, and I'm not sure if the patient was bronchospastic also. So this looks like a very classic presentation of anaphylaxis.
Just tell us how you would proceed in a full-term 37-week about to deliver anaphylaxis.
So this one, so first of all, we have to start off with the usual, airway, where the patient is how is she oxygenating, what is the fetal heart rate, put on the pulse oximeter, blood, and the main treatment of this is actually epinephrine, and we may forget any other ancillary treatments, but epinephrine is the choice. The question is, yes, she is pregnant, but still we have to actually give epinephrine. I'm not sure how it comes as epinephrine in India now. Previously we used to dilute and make it to 100 mics per cc and then give it IV slowly. That is one. And second thing is we can supplement with steroids and we can supplement with antihistaminics. And hopefully we have to avoid, going her into a cardiac arrest in this patient. And most of the times they do respond to epinephrine. And another thing is to keep her airway, to monitor her airway, because I am not sure how this patient presented, but did she have any difficulty in breathing because of airway edema? That is actually one of the features that occurs. If that occurs, then you have to also look at, what is the feasibility of intubating this patient early.
So Dr. Sridhar, can you quickly tell us how you managed this case, and we'll go to the next question.
Yeah, so hemodynamic monitoring was done, and at the same time an obstetric registrar was called to see for the fetal status. These patients will have hypotension as mentioned above. So we gave a fluid bolus, steroid dose of 200 mg hydrocort, antihistaminic chlorpheniramine maleate, that is injection Avil, we get it here. So that was given. Oxygen supplementation, and EBG was sent to determine what is the PO2 levels. And at the same time, the obstetrician has determined that she has to be taken up for an emergency cesarean section. So we had to rush her to the operative room.
Dr. Langford, I'm going to ask you a very uncomfortable question. Now, if this patient coded, how are you going to, this was in the labor unit and she was being induced, she's not in the operation theater, and let's say she is just arrested. So how are you going, you're there on the site, what are you going to do?
So if we are unable to resuscitate within our window of 4 minutes, I would start an emergent perimortem cesarean delivery at the bedside. Generally, I think we've been encouraged not to transfer these patients to the operating theater if it truly is a perimortem. I mean, hopefully with epinephrine, as Dr. Kodali said, these patients turn a corner very, very quickly within seconds. So I would be hopeful that implementing that therapy would resuscitate the mother. But yeah, unfortunately, if not, then we would have to do a perimortem.
Okay, so just a quick note that as you're doing a CPR, you should do this left uterine tilt. This is just to graphically show it to all our obstetric colleagues, how you could, this left uterine tilt. See, the purpose of doing a perimortem cesarean section is to decrease the pressure on the IVC. That is the reason why C-section is advocated within 4 minutes of a cardiac arrest, because the venous return from the inferior vena cava is being obstructed by the fetus. But if you can't do it or there's a delay, then this is what has to be done to push the uterus to one side. So one person should just do that. The other continue the CPR till either you get a return of circulation or you plan a proper C-section. So tell us why this 4-minute window is there, Dr. Langford? Why not 15 minutes? Why 4 minutes?
Yeah, I think because the delivery of the fetus and improvement in the cardiac output, relief of that aortic caval compression, in many times actually does help resuscitate the mother. In the time that she's arrested, there's risk of anoxic brain injury, multi-system, there's malperfusion to all organs. So, I think that's the time frame that if we're going to get resuscitation, if there's expectation that it happens immediately, otherwise that 4-minute window is set so that we don't delay delivery, which could potentially help the mother.
Dr. Bhavani, in your career, which is pretty long in obstetrics, have you had I would say misfortune to see this happen? And if yes, how many in your career and what were the outcomes? The perimortem cesarean sections.
Actually speaking, we have not had, although I've been practicing obstetric anesthesia for over 40 years, I have not had a case of perimortem cesarean section. Maybe because I come to work after praying every day. And somehow
who is your God? Pass on your God's name to me.
we got them intubated, got to the OR and did a stat sections, but not to the point of thing. Although I have heard, the famous Boston case of 32 weeks gunshot injury, and Langford will actually say we do get trauma patients here. And unfortunately, the trauma patients don't come to us as OB anesthesia. The trauma team takes care and they do peripartum, and Dr. Langford team goes and do the C-sections in the emergency room.
Okay, so this is just, how to do a CPR, and we'll now come to the last case. I think we have 10 minutes left. Let's see what best we can do out of this. So this is again a pretty common sort of a presentation. 28-year-old came to hospital in labor at 36 weeks plus 3 days. And she set into labor, asked for an epidural. Her basal vitals were pretty normal. So the anesthesia team inserted an epidural. She had good pain relief. Everything seemed to be going fine. Then vaginal exam revealed lack of progress of labor. Oxytocin infusion was started. And then the dilatation was progressing good. She delivered after 3 hours normally with an episiotomy. So I think it was just a normal scene in our labor ward. But here's the turn. 15 minutes after the delivery, the patient suddenly felt uncomfortable. The blood pressure was now 85/59, heart rate was 140, and respiratory rate was 35. Dr. Jyotsna, can you tell us what you were on the site? What is going on in your mind?
Immediately after delivery, hypotension, there is an increased respiratory rate. If her saturation, we look at the saturation, if there's any evidence of hypoxia, I'm simultaneously thinking of any hemorrhage or an amniotic fluid embolism, thromboembolic event that's happening there. I have to think of both in this scenario because it's just 15 minutes after delivery.
Anyone else wants to add anything? What else could be happening, or are we missing anything? Or should we think of other options as well?
Maybe having an atonic
go ahead.
PPH also.
Yeah, bleeding and amniotic fluid embolism were mentioned. Is there any other possibility should we cross out in our minds?
Postpartum hemorrhage. So that's what I said. Simultaneously, we look for hemorrhage as well as.
Okay. Okay, so this patient was deteriorating and was immediately shifted to operation theatre for further evaluation. There was excessive bleeding from her vagina. There was a poor uterine tone. Some fluids were given, uterotonics were given, and bloods were sent off for cross-match. Now, again, does your diagnosis change, Dr. Langford, or are we still thinking of these two things?
Yeah, absolutely. I certainly think of amniotic fluid embolism in this scenario in a patient with hemodynamic compromise, and then just acute bleeding, concerning for with coagulopathy, and especially in the setting of the atony as well. So definitely still very high on my differential.
So supposing it was amniotic fluid embolism as opposed to a PPH, I mean primary PPH. Of course, an amniotic fluid embolism can end up in a PPH. So how would you manage specifically what is different in your management protocol?
So the big thing, again, is correcting the coagulopathy, which is not unchanged from postpartum hemorrhage, but I think evaluating and managing the hemodynamic side of things, from often these patients have acute right heart failure. And so I think, if they are not improving, or sometimes if you're unable to manage the hemorrhage, often I'll go to hysterectomy very quickly in these patients because you have to remove the source of the bleeding. They generally do not respond to uterotonics or even packing of the uterus or things like that. But also if there's any type of support that we need to provide for the right heart. So again, if these patients, I know that often this does not happen. It's difficult to mobilize for big teams, especially your cardiac surgery teams. But that's something to think about if you need to start off thinking about mechanical support for these patients.
Dr. Bhavani, anything from your side?
No, as I said, although, maybe I'm an exception in certain ways, whenever you see an hemorrhage like this, the two things will come to your mind, whether it is a surgical bleeding or a coagulopathic bleeding. Now, how do you differentiate? Yes, you can send all the labs here, you can do all those viscoelastic. But if you take a single red top tube, and if it doesn't clot in 10 minutes, you don't have to wait to know the diagnosis. You know that it is a straight off a coagulopathy. Now, whether the coagulopathy is because of an amniotic fluid embolism or it is because of the thromboplastin release into the circulation, that we need to figure out. But if it is amniotic fluid, then it is a supportive treatment. But that initial clue, suppose if the blood was clotting, they tell straight away to the obstetrician that this is a surgical bleeding and their intervention is the key here, rather than thinking it is coagulopathy. So that is something which I do very, very often, and I mention to my colleagues every time I have an opportunity.
So I think since we are running short of time, Dr. Shruti, I can't see questions. How do we take audience questions? Or can you help and come in and you can ask the questions? Because I think we should give chance for audience to address their doubts.
Yeah, we have two questions, sir. What anesthesia we give for an arrested patient for C-section?
So there's no anesthesia. If you're arrested, you presume to be unconscious and you don't feel anything. So we don't give any anesthesia, or very minimal, something like maybe a milligram of midazolam just to prevent an awareness when she wakes up. So typically it is absolutely very minimal or no anesthesia. The stimulus, if she wakes up, then you slowly start other anesthetics, because as part of CPR, you are resuscitating, you are intubating, already all that was mentioned. So there's no specific anesthesia as such.
Actually, I think the delegate meant that what type of anesthesia when you are planning for a perimortem cesarean. That is what I think. If we can just give them a clear clarity on that.
I think Dr. Bhavani should answer this, because again, it's the same. Anyway, Dr. Bhavani, maybe you will come across more clearly.
No, see, suppose if someone is arrested, it is most likely the patient will not have any sensory feeling. So this is more of a resuscitative attempt here. Once you successfully resuscitate and the patient is showing signs of life, then you can give, as Dr. Subramaniam said, you can give some midazolam so that the patient doesn't remember and go from there. But majority of the times is a situation where the patient has got a CPR, is ongoing. It's very, very unlikely that they will have a remembrance of this.
I think that's clear, sir. Thank you. And there is another question. 34 weeks antenatal patient with hemoglobin 6.4 was given iron sucrose, had reaction, tachycardia, rashes, and resuscitated. So they're asking when to proceed for blood transfusion.
I didn't understand. So you mean what is the transfusion trigger? Should they have given
IV iron, sir?
Yeah. So they gave IV iron. She had a reaction, but the
she had a reaction, and the hemoglobin was 6.4.
Correct, but the question is, should she have been given blood transfusion now?
They are thinking that to improve the hemoglobin, when can they go for blood transfusion if this patient requires blood transfusion or she's symptomatic at 6.4?
Sunidhara, I think you can answer that.
If the patient is not favorable for IV iron therapy and she is 34 weeks, our trigger for blood transfusion, packed cell transfusion is actually 7 in our unit. So if she doesn't have any other, comorbidities like a heart disease or a respiratory problem, she can still go ahead with oral iron therapy for the next 4 weeks. That would increase probably to 8. And then if in case she really requires blood transfusion because of bleeding during the operative procedure or the vaginal delivery, then we would think of blood transfusion.
Can we manage amniotic fluid embolism in a peripheral setup before referring her to a higher setup?
Sorry, what was the question?
Can we manage amniotic fluid embolism in a peripheral setup before referring her to higher setup?
See, one thing I want to say, if it is amniotic fluid embolism, the whole scenario is just very, we are talking minutes and hours rather than you don't have decision-making time. So you first have to resuscitate. You can't, by the time you ship that patient, she may die. So it all depends on at what stage you pick up. So if you've picked up, the blood pressure is good, you think she will be stable during transfer, probably you could think of it. But if it is a proven or very high suspicion of amniotic fluid or a major bleed ongoing, then I think the best chance for that patient to survive is at your own unit. Maybe someone should come there to help you as you are doing your resuscitative effort.
Yes,
that's what I would say, unless some other panelists say something else.
Yes, sir. The last question is to Dr. Allison. What is the incidence of beriberi-induced heart failure in pregnancy?
I don't know the answer to that question. I mean, I think it probably very, very low. I have never seen that. I've seen, a Wernicke's encephalopathy, and I've seen a GI beriberi, but I've never seen a beriberi that presented with a cardiomyopathy in pregnancy.
Yeah, this question is from me actually. I'm raising this question about this prolonged tocolytic therapy, which is a risk factor for your peripartum cardiomyopathy. You said it is terbutaline, but do you see that there is an incidence of peripartum cardiomyopathy even with the duvadilone? Duvadilone is like
isoxsupreme. Isoxsupreme.
Yes, isoxsupreme.
I don't have any experience with that. Certainly for our tocolytic therapy, we'll use magnesium or terbutaline, or and prior to when I started, we would use terbutaline pumps, and I think that was primarily the association with the cardiomyopathy. So I think since we're no longer using those, that incidence has significantly decreased, but I have not seen it with prolonged use of magnesium sulfate.
Yeah, here in India, most of them might use this prolonged duvadilone treatment as an OP basis. So I think our delegates, we need to learn from that prolonged tocolytic therapy is a risk factor for peripartum cardiomyopathy. And when it is there with terbutaline, it's the same group of medicine. So I think that care we need to take. So it's a good learning point for us. Thank you, Dr. Madison.
So I think we have concluded our session. I thank all the participants, especially Dr. Bhavani and Dr. Langford, who joined very early in the day, putting aside their clinical schedules. Thank you so very much, and we appreciate your support in making this conference successful. Thank you very much, Dr. Jyotsna and Sunindra too.
Thank you, sir.
Thank you very much.
Dr. Maitri, please take over.
Thank you, Dr. Subramaniam and the panelists. I think that was a very thorough and informative session. We next have our keynote address by Dr. Bhavani Shankar Kodali on peripartum collapse. So you can share your screen and start the presentation, sir.
It says I cannot share screen.
Subramaniam sir, you'll have to stop sharing, sir.
Okay, fine. Got it. Is it gone?
Yes, sir. Sir, now can you try, Dr. Bhavani?
Yeah.
Yes, sir, we can see it.
Okay, good. You can see my screen now?
Yes, sir. We can see your screen, sir.
Okay, very good. So, as I said, collapse in the parturient. And as I said, I've been doing this for 40 years now, over 40 years, maybe 44 years. And I always, whenever I take call in OB, particularly in the night, I always think that nothing should happen on my call, which is untoward. And I'm always happy to do a complex Eccrita case during daytime rather than taking night calls, which I don't know what is going to happen. Now, I have disclosure that I do maintain a website, as Dr. Subramaniam said, on capnography. And I also maintain a website on a pain-free birthing. This is about what are the pain-free birthing.
Dr. Bhavani, sir, I'm extremely sorry to interrupt you, sir. Can you put your slides on a slideshow mode, sir?
A slideshow mode? Okay,
yes, sir.
One thing. I may have to share the right one. Okay, can you see now?
No, sir.
Okay, let me just give me 1 second. Let's see if I can see now. You can see it now?
Yes, sir. Yes, sir. Thank you.
Good. Good. So this is a pain-free birthing options for the patients, and it is also there in several languages, including Telugu also. Now, maternal collapse is very rare, but it is a life-threatening event with a wide-ranging etiology. That is number one. Number two, the outcome is primarily affects the mother, as we have seen, but it also affects the fetus, and that is why the decision-making is important. You have to look at the mother as well as the fetus. And the third one is the outcome also depends on prompt and effective resuscitation, which we have actually seen from some of our cases. Now, this is a very good article actually in the British Journal of OBGYN, which you should probably all should read, which is Maternal Collapse in Pregnancy and Puerperium, which they update probably every couple of years. Now, according to that, the incidence varies from country to country, but it is roughly about 1 in 36,000 according to their report. The case fatality rate is 42%. And this is important to know. And what is more important is 25% of the cardiac arrests occur during anesthesia, and they have 100% recovery, which is a good thing to know. Now, as I said, the incidence is variable from country to country. In Maryland, in one of the reports that was published by us, 28 cases of maternal cardiac arrest occurred in about 118,000 deliveries, with an incidence of about 24 per 100,000. And three primary causes were amniotic fluid embolism, peripartum cardiomyopathy, and of course, the first one is hemorrhagic shock. And the maternal survival is again about 50%, and the fetal survival is 93% in this study. Now, in India, one of the articles by Sunanda Gupta, and she quotes a figure of 1 in 20,000. And Dr. Sunil Pandya, in his article, he actually says that it is about 1 in 254. And Dr. Subramaniam has highlighted that it is much lower now. It is very good. Now, this is an article from from Chopra et al. From the Lady Harding, and they highlight about maternal cardiac arrest and how to go about it and what are the causes of it. Now, when you look at the causes of maternal collapse, mostly they are obstetric related, like we discussed: amniotic fluid embolism, thromboembolism, hemorrhage, magnesium toxicity, and eclampsia. Anesthesia related are high regional anesthesia and local anesthetic toxicity. These are the two prime things that can lead to cardiac arrest. Then there are cardiac, as we talked about, cardiomyopathy, aortic root dissection, or valvular defects, particularly common in India. Then infection, septic shock should be always kept in mind. Then metabolic, like hypoglycemia. And then, of course, trauma. I'm not sure how common is trauma in pregnant patients in India, but it is fairly common here. And of course, general, which is anaphylaxis, and we did discuss this case too. Then American Heart Association actually, they classify causes according to the alphabetical list, but they are all same as I alluded to. Then the paper which came from Lady Harding, they go with 5 H's and 5 T's. And again, this is another way of classifying. This is a good picture to have so that based on this figure, we know what could be the cause of a cardiac arrest, what we have to look when there is a maternal cardiac arrest. Just by looking at the picture, it gives us, okay, these are the things which we have to rule out in our differential diagnosis. Now, what are the risk factors for maternal cardiac arrest? One is age, greater than 35 years. Then obesity is the second one, which probably not that common in India, obesity yet, but may occur in future. But I do see a lot of obese patients in India too. Then cardiovascular diseases, as we have alluded to. Then maternal comorbidities like asthma, hematological disorders, or autoimmune disorders. Then cigarette smoking, substance abuse, and alcoholism, which are very, very common, at least in this part of the world. And the lower socioeconomic status is another risk factor for maternal cardiac arrest or collapse. Now, I'll give you some of the examples as we go by. A case, epidural was placed at 2:30. She coughed around 15 hours, a transient decrease in oxygen saturation. And at 16 hours, the drama starts, called to the room for PPH, to the OR for vaginal bleeding evaluation, and look at her first set of coagulation. You can see a fibrinogen of 60, PTT is 103, and INR is 6.1. This is the classic presentation of amniotic fluid embolism. This probably is not surgical. So this is why I was actually asking, just a simple red top can give us the answer before this labs come. So someone was asking, how do you manage amniotic fluid embolism? They're mostly supportive, as shown in this. It is one of the most dreaded complications during childbirth, and it is most dramatic. And that is why Dr. Subramaniam was pointing to that there may not be any much time to transfer these patients elsewhere. So if you can stabilize it, yes, you can consider transport to the other institutions. Then the treatment, as I already said, it is supportive, intubation and ventilation, treat coagulopathy, CPR, and some well-established center. An option is to go on bypass or ECMO. There are some reports that have successfully treated amniotic fluid embolism. one thing I have to emphasize, if there is no coagulopathy, it is most likely not amniotic fluid embolism, and try to look for other causes of maternal collapse. Now, this is another case, a 25-year-old, 25 weeks, had cholecystitis. So she had a laparoscopic cholecystectomy, but she was obese. She was transferred to L&D after laparoscopic cystectomy. The fetal heart rate was normal. The next morning, she becomes hypotensive, lost consciousness. So she was intubated. Inotropic support was started. She was transported to ICU on ventilator, and because the fetal heart rate was still good, and finally she had to go on ECMO because the patient had actually thromboembolism, pulmonary thromboembolism. She went on ECMO, she came off ECMO, went home, and then came back at 39 weeks for normal vaginal delivery. So this is the classic example of pulmonary thromboembolism. Now, this is an example, another example, a full-term uneventful epidural was placed, negative aspiration, full loading dose was given to her, infusion was begun, she became unconscious. She was taken to the operating room, intubated, and then everything, differential diagnosis was being worked out, and the aspiration of CSF was positive for the epidural catheter. So this is a total spinal, but she recovered very well. That is why we said 25% of the maternal cardiac arrests are anesthesia related, but the success rate is almost 100% when we take care of them immediately. Now, the reason why this happens here is because normally this is the epidural space. Sometimes the catheter can go into the subdural space, and this is the arachnoid membrane here. And as we give more and more epidural infusion, the subarachnoid membrane bursts suddenly, and then the whole of the local anesthetic floods into the CSF, producing total spinal and maternal collapse. In this patient, everything seemed all well until 4 a.m. actually. The resident called me and said, the patient has got numbness of nose and tongue. Aspiration was negative initially, but when I disconnected the epidural catheter from the pump and left it to the gravity, I saw the blood coming. So this is a classic intravascular catheter, and those are the very early symptoms. Numbness of nose and ears and the tongue, tip of the tongue are the early symptoms. If we give local anesthetics through that, then it becomes a local anesthetic toxicity and can result in maternal collapse. And that is why wherever anesthesia is provided for pregnant patients, a regional anesthesia, intralipid must be always kept in stock. And this is something that is available very widely in India too. Now, in this example, this patient had retained placenta. So patient for manual extraction of the placenta in the operating room. So we topped up the epidural, went to the operating room. There was a torrential blood loss of 1800 ml, very suddenly. And the monitor showed a heart rate of 35 and the blood pressure of 69, as you can see here. So immediately we gave, phenylephrine, ephedrine, etc. But then, because of the sluggish circulation improved, there was a sudden flooding of the inotropic drugs into the circulation, and patient had a rebound hypertension. Of course, we managed the hemorrhage okay. But then, because of that, the patient had chest pain, and she was resuscitated with all this. We also gave actually tranexamic acid and also fibrinogen. This is extracted fibrinogen, 2 grams. She had a rebound hypertension. She complained of chest pain, but she was stable. EKG was normal. Troponin leak was there, and she gradually normalized in the next few days. That means this patient did have some sort of a cardiac damage because of the sudden, influx of those drugs, because she was almost in a very low circulation phase When the circulation improved, all the drugs went into the circulation and produced a rebound hypertension. Now, this is a classic, eclamptic seizures of, that can result in maternal collapse. 32-year-old, 33 weeks pregnant, she seized, she lost consciousness. Oxygen was given by mask. She was hemodynamically stable. And, she regained her consciousness very well. So they posted for cesarean. Actually, we did this case under spinal. In another scenario, just happened about 3 weeks ago, the patient seized and lost consciousness. They had to intubate the patient, take to the operating room, do an emergency cesarean section, to the ICU, and then she was extubated later. So eclamptic seizures is one of the also things that results in maternal collapse. Now, this is a case report in the Indian Journal of Obstetric Anesthesia, and it is actually pulmonary thromboembolism case that occurred during cesarean section, and they actually gave thrombolysis by streptokinase, but then that resulted in hemorrhage during the case. But anyway, ultimately the patient did fine. So this is another example of maternal collapse because of pulmonary thromboembolism. Now, a while ago, I had this case. She was, starvation ketoacidosis. She was found on the street or in the house, I believe. She was brought here. Her blood sugar was 57. And look at her blood gases. 7.19 is the pH, and her bicarb was 7. And she also had vaginal bleeding. And also there was a fetal heart rate variations. So I was a little worried that the obstetricians may call for a section, and giving anesthesia with a acidotic patient is not that good. It is probably dangerous. She can arrest during anesthesia. So fortunately, the vaginal bleeding was not that much. The fetal heart rate was also not to the point of calling for a section. We immediately put an A line, started the IV fluids, treated and we gave all the vitamins, and we also gave bicarb infusion, and we corrected the bicarb over time, and everything normalized. And subsequently, she came for vaginal delivery. Now, in this case, 32 weeks intrauterine growth retardation. So this is the case which I was telling about cardiomyopathy, which I was completely bowled by this case. Now, she was posted at 32 weeks because of IUGR, and she was walking very briskly in front of me to the hospital from the garage. In fact, I was seeing a pregnant lady going in front of me, overtaking me and walking. I thought she must be heading towards our unit. Maybe she's for cesarean section. In the history, 3 days prior to cesarean section, she had little cough, and X-ray showed some sort of a haziness here on the X-ray. So anyway, we gave I asked for a repeat X-ray. There was no change and looked fairly normal. So we gave a CSC, uneventful cesarean delivery. But there was a progressive shortness of breath in the next 4 hours, and that resulted in florid pulmonary edema. And she was intubated, went to the ICU, and overnight on ventilation, extubated next day. Her echo showed an ejection fraction of about 25 to 30%. And she made a full recovery with Lasix and ventilatory support. So this is the one I said, Dr. Subramaniam was pointing to, that we have a system of referring anyone who is short of breath. This lady was actually not short of breath. I mean, she was doing all well, except she had cough. But putting retrospectively back, maybe this is how she presented 3 days, with little cough, and they thought it was asthma. So sometimes we get caught, without our knowledge. Now, this is a case where this happened just a week ago. She had, she had a normal cesarean section, prior history of postpartum hemorrhage. It was a second section. She had hemorrhage again, and they gave about 4 liters. She lost about 4 liters of blood. They put B-link suture. They thought everything is fine. She continued to bleed in the recovery room. So they did an hysterectomy. So she lost total about 5.2 liters. And she was actually very well resuscitated with everything. But then, so she was transferred back from ICU to us. And I was on call on the Sunday, last Sunday. If you look at the heart rate, it was 110, I'm sorry, just let me go back. It was 110, 109, 107. And look at, suddenly it went up to 200s. And this is the time they called me. They said, can you please step into this room? And I go there. And my differential at that time, she was still conscious. Her SATS was 93. I put on some oxygen. And her hemoglobin was around 7 prior. And then I was thinking, is it continuing hypovolemia because she had 2 surgeries already in the abdomen? Or is it some sort of an embolism? So what I did was I put it Massimo, the Massimo non-invasive hemoglobin, which is a very good thing. I put it on. It was still reading around 7 grams. So I know that she has not lost blood. So I gave phenylephrine. The blood pressure came up to about from 70s to 80s, and the heart rate didn't budge. So I gave 2 units of albumin, which is 500, and continued with phenylephrine boluses and gave esmolol. And the heart rate, as you can see, came back to 97. And after she got little stabilized, we sent her to the CT, and CT showed acute pulmonary embolism in the main pulmonary arteries, extending into the segmental and subsegmental pulmonary arteries in all 5 lobes. And her echo showed right ventricular dilatation, right ventricular dysfunction with straightening of the septum. That means there is a right ventricular strain, and her left ventricular ejection fraction was 25%. So she is doing fine now, actually. They started on heparin and she is fine. Now, so these are some of the cases, but sometimes there are certain preventable incidents where you can avoid a maternal collapse. For example, when we are doing patients under regional anesthesia, particularly they are obese and they strap all the abdominal, the abdominal wall to the bed in order to make their incision, we are compressing the aorta and the IVC, and maternal cardiac arrest can occur. And prompt treatment of maternal cardiac arrest has led to anoxic brain damage and a lot of medical legal cases. So therefore, after regional anesthesia, one has to carefully monitor the blood pressures and correct them quickly. Otherwise, maternal arrest can occur. And particularly, we are doing obese patients, it has to be kept in mind. Now, another interesting thing is the following, the bicarb in some cases. Now, this patient actually came, she had a liver transplant, and she came for delivery for her, for her baby. And when you look at, when she came with the bicarb, see, this is what I was telling about the CO2. We actually, our lab also gives the CO2. When you look at the CO2, it was 17, 19, 18, 15, 14, 11. It was just decreasing. That means her bicarb is decreasing. And this was not actually detected until what happened was she had cesarean section. She became hypotensive in the post-operative period. At that time, the A-line revealed a bicarb. Someone saw these values and the A-line bicarb was 5. She was immediately transferred to ICU and corrected, and she was fine. So this is sometimes is very important that when we hand over patients from one person to the other person, sometimes the handover may be incomplete and we miss these kind of values. And that's why whenever I do a cesarean section now, I actually look for the CO2 values just to see if the bicarb is low, as you can see in this picture. This is another one of a similar story. Her bicarbs has been low in the first admission because of ketoacidosis, as you can see here. It's been low. And even in the second admission, it was also low. And I came on a call after this, around on 18th, I was on call. I looked at these values and started bicarb infusion and corrected the bicarb. Subsequently, she had a cesarean section, as you can see in this picture. Now, we all know that if someone is acidotic, they can have, the variability can be limited, and they can have fetal bradycardia. In fact, in one of the cases, they called for a section, and because of the minimal variability, and when I looked at the bicarb was low, and we gave some bicarb, and you see how the variability has actually improved. So sometimes you have to keep these things in mind. See, whenever someone is acidotic, anesthesia can produce hypotension, and that could lead to maternal collapse. Now, what happens to fibrinogen during obstetric hemorrhage? That is one thing which we have to always remember. And fibrinogen actually takes a nosedive. And particularly the fibrinogen comes below 200, it's a positive predictive value of 100% for postpartum hemorrhage. Now, in this particular case, what happened was the case which I showed that they lost 5.2 liters. There was a delay in giving her the plasma and cryoprecipitate. And when they did a ROTAM, the AFib, the A10, which is an indicator of fibrinogen, is actually 2, and her fibrinogen was actually less than 60. So this scenario can be avoided by giving either FFP or a cryo or even a fibrinogen much earlier, so that you can prevent ongoing bleeding. Subsequently, of course, it got better, as you can see in this. And I did ask our colleagues, did you do a red top when this sample was sent? They said, well, they did not do. And I said, if you did a red top, you would have known that this patient is coagulopathic. And subsequently, she did fine. Now, I think everyone should know, to avoid a maternal collapse and bleeding, how to give abdominal compression to compress the aorta. This is a very simple thing that can be given below the sternum, above the umbilicus, and particularly in a slim patient. Compress the aorta against the vertebral column until you control the bleeding or you catch up with the resuscitation. And Dr. Kausalya and her group from Hyderabad, actually they are using this for placenta accreta cases. Now, since these causes of maternal collapse are treatable and preventable, you must have a systematic approach, is mandatory in your setup to tackle these problems. Obstetrics as such is a high risk business, which we all know that. Second, the maternal mortality is high. Complications that occur, during anesthesia are preventable actually, and that is important. And if complications occur, they are treatable. That means many complications that occur in pregnant patients are treatable, and therefore we can avoid a maternal collapse. And experience and training becomes, to treat these complications is mandatory. That means you have to train ourselves, we have to get ourselves sufficient experience to manage this. And that is the reason is we should adapt a system in place to activate whenever a problem occurs, because most of the complications are preventable and treatable. So every obstetric unit, irrespective of what is the size, must have some sort of a resuscitative equipment at hand, and everyone should know where it is and what it contains. Even a simple setup like this, having them in a trolley, will be a great boon when there is a complication during our practice, and we can prevent a maternal collapse. In fact, I did write an article a while ago for IJOVA, establishing an obstetric neuroaxial service in low resource areas. The definition of low resource is it is not financial, it is even the staffing. So, and how to establish this service, in that I did mention that every unit that provides that takes care of pregnant patients must have resuscitative equipment available to save mothers from dying. Now I will give some sort of, some sort of an algorithm how to manage these patients. Now, the first thing, whenever there is a maternal collapse, look at if the patient is unresponsive or responsive. If the patient, although the management strategy is same in both, at least if someone is responsive, it is much better than to have an unresponsive patient. Now, if the patient is unresponsive, then you call for help. You activate help and look at the fetal heart rate, because the fetal heart rate there will dictate our further management, whether it is urgently we have to deliver the baby or we can follow this protocol. Now, if the patient is unconscious and breathing and the circulation is present, then you look at the pulse oximeter, blood pressure, and heart rate. So depending on that, either you oxygenate and protect the airway, and hypotension, if the patient is hypotension, you treat. And as you treat, you look for the differential diagnosis, whether there is a seizure like eclampsia, or there was magnesium toxicity, because we all give magnesium for preeclamptic patients, so there can be magnesium toxicity, or whether the patient is hypoglycemic. Then, is it a complication of a regional anesthesia if the patient has a regional anesthesia on an L&D floor, like high spinal or local anesthetic toxicity? So you have to think through the differential diagnosis. Now, when there is a bleeding, then you think through the differential diagnosis of bleeding. If the bleeding is ongoing, the patient has to be intubated, go to the operating room, as we discussed, and manage that. Then we have to, in the differential diagnosis is very high, is of course pulmonary embolus or cardiomyopathy or valvular diseases. Now, if the patient is unconscious, no breathing, no circulation, then you initiate the protocol of CPR, which Dr. Subramaniam has alluded to. Left uterine displacement, disconnect the fetal heart rate. The fetal heart rate monitoring must be disconnected when you are giving shocks. And then you follow the 4-5-6 rule. Now, why we follow this 4-5-6 rule is, at 4 minutes, you have to decide whether you have to call for a cesarean section if mother is not resuscitated. At 5th minute, you actually start assembling, and 6th minute, you do the cesarean section and deliver the baby by 7 minutes, because beyond 7 minutes, the neurological outcome of the baby is not that great. That is why we follow this 4-5-6 rule. So this is sometimes which you may have to, that means when there is a maternal cardiac arrest and you're trying to do a cesarean section because the patient is unable to be resuscitated, because once you deliver the baby, the resuscitation will be much more successful. That's also a good reason. But someone should time the time of cardiac arrest and when we should call for 4-5-6 rule. So someone should time when the cesarean section should happen. Now, since I'm a very strong proponent of CO2 monitoring, whenever there is a CPR being done and the patient is intubated, the CO2 should be monitored, because it gives you an effective idea how effective is your CPR that is being done. Now, this strategy which I just explained cannot be done effectively if no thought was given before. That means you have to think through these things before and have a system laid out in your hospital. The process should be delineated at your workplace and use your resources of other departments. That means you cannot by yourself do these things. You have to assemble all the other departments, particularly if there is a hemorrhage, the blood bank. If it is a cardiac issue, the cardiac group. If there's an ICU problems, the ICU group. Then you have to train all the participants, and you have to test this process whenever, occasionally, so that you know that their process is working. And we should never find reasons why this cannot be initiated and established in your institution. Now, this was recently, we had the Association of Obstetric Anesthesiologists of India, where there is a small video on the simulation, as you can see, in this video, where you must have this kind of simulation. So when there is a problem, everyone knows what to do, how to do, and how to give the left uterine a displacement, and then how to do the chest compressions, ventilation of the patient, what are the drugs to be given, where the drugs are located. And so this must be practiced under simulation. So what are the conclusions of this so far? Most of the obstetric complications are preventable. That's number one. Number two, they are treatable complications. So which is very good. If we act, probably our results are good. Foresight and preparation is required. I explained to that. You must have a system in place and not wait for a complication to occur and then think, oh, okay, what to do next? You must have a system in place. You simply activate the system when there is a maternal collapse. Practice sessions must be undertaken periodically so that you know where you stand in this process. Some cases may need transfer to the tertiary centers before surgery, because if there is a complex obstetrics case, you have to see whether your institution can handle it or you have to send it elsewhere where they may have other facilities to support the patient. Some cases need transfer after stabilization, which we have already discussed. You have to stabilize the patient and make sure that the patient can withstand during transportation to a bigger center. Learn from experience and set aside our personal egos. Change practice to better. If you think that we have a better practice or someone is doing better, there's nothing wrong in adapting a successful management strategy into our system. Then not I that matters, but we that matters. You have to foster teamwork, because this is very important that you foster teamwork and respect each other. Ultimately, it is not one single person that saves the life of the patient. It is a big team that that works for that patient, and finally you have a good result when there is a maternal collapse. Build a robust, trustworthy team of care providers to guarantee success, and that is the last one. So a maternal collapse, a roadmap to optimizing maternal outcome. We should always go in the direction of the success. And I think if you follow what I have outlined in your institution, certainly you will succeed in our, in our goals of successfully, resuscitating a collapsed pregnant woman. Although I said that I always pray and come, I shouldn't have a maternal collapse, but it is inevitable and we should be always prepared to tackle. Thank you so much for giving me this opportunity. Hopefully I will see you live next year or so.
Yeah, thank you, sir. I just have one question for you, sir, from the audience. Obese term second gravida patient with a previous C-section, complaints of uneasiness, wanting to pass motion. This lasted for 4 hours. In this 4 hours, vitals were stable, uterine scar was intact, no abruption, and all of a sudden patient had thrown seizures and cyanosis, hypotension and collapsed. Resuscitative steps were done from first seizure, but within 5 minutes patient died. So the differential diagnosis for her cause of death is what is the question, sir?
What was the, can you just give me the initial events? I was not clear.
So it's just a second gravida patient with previous cesarean section. Probably she got admitted for a planned cesarean section. I'm not sure, they have not written, sir, but complained of uneasiness and she had that urge to pass motion. That bowel movement, that urge was there. That's it, which lasted for 4 hours. And in that 4 hours time, the patient's vitals were stable, but she had sudden seizures, cyanosis, hypotension, and she collapsed.
okay, this looks more like a cardiac issue or an amniotic fluid embolism. Was she in labor?
They have not mentioned that. I'm suspecting that probably patient was admitted for elective section or some uneasiness in the term. At term.
Yes. Yeah, I mean, this looks like more like a cardiac issue. I don't know whether any myocardial infarction, because you said there is a urge to push, and it's very unusual that they die without any explanation. There has to be something just before the collapse. Was the patient heart rate was okay? Was the blood pressures were fine? Whether she has been saturating well all along, or did she rupture uterus? What did they do afterwards? Because it all depends upon what happens after when she died.
They tried to resuscitate, it seems, and in 5 minutes the patient died. I'm not sure about the resuscitative measures, to what extent they have given.
Yeah, and the baby, they did not do a section.
Yes, sir. They have not done a perimortem cesarean. They have not done it.
They have not done it.
Yeah.
Okay. Yeah, it is very difficult to give what it could be. Usually if it's amniotic fluid embolism, I said maternal collapse can occur, but there is a coagulopathy. Patient should show some signs of bleeding. This looks like some sort of a cardiac, that she have a undiagnosed valve, valvular lesions, like a mitral stenosis, and which was never diagnosed before, and suddenly she presented with this. Maybe Dr. Subramaniam still online? Maybe he can throw some light on it.
Yes,
or
sir.
any of you, because I can't figure out from that.
I think it's the same. I would agree that without any information, it's very difficult to postulate.
Yes.
Another question from me, sir, regarding that case 9 where you were not suspecting peripartum cardiomyopathy. Based on this, what do you say? Because we once, like last year, we had a WhatsApp forward for all obstetricians here that it's better to routinely do echo at 32 weeks.
Yeah. So, something, Dr. Langford was the obstetrician that day. And she was actually hitting her head. She said, "Oh, Bhavani, I should have done this transthoracic echo in the morning." In fact, what happened was, the morning of the case, I saw her overtaking me and walking. So it never struck me that she has anything. She was so agile. That's number one. Number two, I asked for chest X-ray because the previous X-ray was doubtful about some haziness. So I didn't want that X-ray deteriorate before I started, because I thought, for some reason, my mind, I was thinking, if there is a post-operative problem, the comparative X-ray is the 2 days earlier. Maybe we should take an X-ray. In fact, Dr. Langford said, "Oh, Bhavani, we don't need an X-ray." I said, "No, Dr. Langford, let's take an X-ray." So they got the X-ray. It looked okay for me. See, that X-ray was a comparative film for what happened in the 4 hours later. She has florid pulmonary edema. If I didn't take this X-ray, I would have thought maybe she had these findings in the morning, little bit of pulmonary edema, and I missed completely. So it turned out to be a cardiomyopathy. Now, is that evidence what she presented on Friday with little bit of, like an asthma thing? That should give a red flag to do a echo. It's very difficult. Retrospectively, she was thinking, "Oh, Bhavani, I think we should have done an echo on her." Yeah. So it's very difficult. That is why I was telling, when Dr. Subramaniam was pointing out that whenever someone is short of breath, we should do this. Probably yes, but it's so difficult, because what is the yield of doing echoes for so much, and then we don't see any, our positive results, because we're spending so much of time, so much of money on it, and things.
Yes, sir. Actually, we had a similar case, second gravida, previous normal delivery. I think Subramaniam sir also knows about this case. We were we got a telephonic call that we are going to refer one patient with cardiomyopathy. So we were all prepared, and the patient came in walking, no symptoms, nothing, absolutely normal. And when we didn't trust that echo report, and when we did our echo ourselves, then we thought, we came to a conclusion there's a peripartum cardiomyopathy. So she was completely asymptomatic. Luckily, she didn't have any problems because we knew that there was a diagnosis, and then we took all that care. So patient went
exactly.
fine.
I mean, absolutely. If I had known that this patient has got cardiomyopathy, I would have probably given Lasix and everything. I would have been more aggressive. And I didn't know. And I was completely surprised, bowled completely, because she overtook me and went. And when I was walking to the, so it never struck me that this lady has got some shortness of breath. So it is very difficult. See, pregnant patients are very, very difficult sometimes to interpret. I mean, we think that, pregnancy is so easy, everything is fine and thing. How many times when a normal pregnant patient complains of little shortness of breath and, I mean, you all know, when you take a history, they say, yeah, I feel a little short of breath. But then you have twins and, of course, you will be a little short of breath. So it is very difficult. I don't know, I have not come up with anything which I should. But obviously, if someone is short of breath, visibly short of breath, if that lady had, say, little bit of shortness of breath while talking to me, or she was short of breath while walking, or some saturation issues, I would have certainly, asked for a thing. But she didn't have anything until, postpartum.
Yes, sir. This patient also, the ECG was completely normal because we didn't trust that echo report, and the ECG was completely normal. And the echocardiologist has, like when he did the cardiologist has done the echo, he confirmed that it is peripartum cardiomyopathy.
Yeah. Yeah, that is true. And I gave you another example that, during this COVID times, when we were trying to review, there was a patient who is 34 weeks twin pregnancy. They put a spinal and she went into pulmonary edema. And then the ejection fraction was 25%. But when you look into the history, yeah, she's twin pregnancy. She was complaining of occasional short of breath, while climbing stairs. So it's very difficult, we can't blame the clinicians of not having picked up. It's not that easy, I should say.
Yes, sir. Thank you, sir. Thank you.
But what is more important is, if there is a problem, we should be able to take care of that. And the patient should not die from that. That is my point of this. That's why I said you cannot prevent, however diligent you are, but you must be able to treat them and, get them to, to the normal again.
Yes, sir. Thank you. Thank you very much, sir. Maitri,
our heartfelt and special thanks to Dr. Bhavani Shankar Kodali and Dr. Alison Langford for participating in this webinar despite the odd timings and their busy schedules. Thank you, sir. Thank you, ma'am. I would like to express our sincere gratitude and appreciation to all our faculty members and delegates for their invaluable time. We have an exciting day ahead of us tomorrow with very interesting topics. We hope to see you all again tomorrow. Thank you and good evening.
Okay, thank you. Bye.
Thank you, sir.
Thank you. Take care.